Great. Will there be okay? We're good? Okay, great. Thank you so much for attending this morning at our annual Hydrocephalus Symposium. It's truly a pleasure to be here with all of you. I know that there's many of you on Zoom right now, so I'm thrilled that you're going to be here with us throughout the day. Let me tell you a little bit about Jersey Shore University Medical Center and K. Hovnanian Children's Hospital. Jersey Shore University Medical Center is one of the fastest growing hospitals in the state of New Jersey. And the quality of care, the experience that we deliver is really phenomenal for families and children. K. Hovnanian Children's Hospital is ranked as the #1 children's hospital in the state of New Jersey. And we provide a full spectrum of care. All of our subspecialties are represented here. We have an amazing primary care team, as well as many surgical subspecialties. And you'll hear a little bit more about that today. Myself, I'm Dr. Harpreet Paul. I'm the chair of pediatrics, and I'm a practicing pediatric gastroenterologist. Let me tell you a little bit about the landscape in children's health around the country. We've had a challenging time across the country, right? We've been through a pandemic for the last several years. Now we're out of the pandemic, but still the healthcare environment is challenging right now. Access problems, making sure that we can provide care to kids from all sectors of life, no matter what their socioeconomic status is. Making sure that the quality of care is amazing based on some of the challenges that children's hospitals are experiencing. Here at K. Hovnanian Children's Hospital, I believe we've done an amazing job based on the talents of the teams that we have. We've got really passionate, dedicated, committed nurses, physicians, respiratory therapists, you name it, an entire team who is only here to take care of kids and treat them like their own family. So what's the vision for K. Hovnanian Children's Hospital? Well, we exist here only for one reason, and that's to provide the best possible care to kids and to their families. It's not fair that kids or families need to leave the state of New Jersey to get pediatric health care. So we aim to be the destination for children's health in this region of the state of New Jersey. That's why we exist here. And I think that we are making significant strides towards that vision and that goal. We are an academic children's hospital. That means that we have training programs. We've got a pediatric residency program that has been here for about 50 years. We've got a new child neurology residency program, and that relates to Dr. Daniels and the neurosurgery program. That's a child neurology residency program that spans the state of New Jersey. So we have our residents that do their foundation training here, but they also go up to Hackensack University Medical Center and to JFK Medical Center as well. In addition, we have a child psychiatry fellowship, and we are one of the strongest child psych programs in the state of New Jersey. We have about 15 or 16 child psychiatrists here at K. Hovnanian Children's Hospital. We have our new fellowship, and we also run a grant throughout the state of New Jersey that provides access to kids who have mental and behavioral health crisis. So that's really a groundbreaking opportunity to ensure that we can work to prevent crisis so that kids don't feel like they need to come to our emergency room. In addition to our training programs, we also do research. We have several significant grants, including the psychiatry grant that I just mentioned. We also have a grant called the INC grant, which is a $50 million grant to make sure that kids who have who come from medical complexity, which means they have multiple medical issues, that they have the right resources to be able to get the care that they need. And finally, and perhaps most relevant to today, we have great clinicians, great nurses, great doctors across all pediatric specialties and surgical specialties. Let's talk a little bit about neurosciences. we have a very strong interest and passion in providing the best possible care to kids who have neurologic and neurosurgical issues. We've got a team of pediatric neurologists that work very closely with our neurosurgeons, and Dr. Daniels, which I'll talk to you a little bit about, is our chief of pediatric neurosurgery. We also have an outstanding adult neurosciences program. We've invested a lot of time and energy in building both the adult and the pediatric neurosciences program. And I would dare to say that we are probably the fastest growing neurosciences program in the state of New Jersey as well. So really the recognition goes to the teams that take care of kids and adults day in, day out, to make sure that we could provide the best possible care. We have, in addition to some of the other services that I've spoken about, pediatric physiatry, so that's PM&R, pain, physical medicine and rehabilitation. Oftentimes, kids that have neurological diseases, they need rehab, they need specialists that are trained to work with multidisciplinary teams to be sure that we can get kids back on the path to the best functional life that they can lead. And we're proud to be able to offer that service here as well. We've got a team of rehab occupational therapists and physical therapists as well that work very closely with our neurologists and our neurosurgeons. And we've got developmental and behavioral pediatrics. So kids that may have autism or other developmental delay, that team works very closely with our neurologists and with our neurosurgeons to be able to provide the full spectrum of care to these families. And as you may have heard, New Jersey has a very significant number of kids who have autism. So we do have a focus on ensuring that kids who have autism can get the access to care and get the compassion and the empathy from our team members to be able to care for them as well. So I think that we're doing a great job with that. Our surgical program at Cape of Canadian Children's Hospital is growing very rapidly. In addition to our neurosurgery program, which I'll get into in a minute, we've got a very busy pediatric general surgery program with 3 general surgeons who are absolutely phenomenal, and any one of our team members would take our children to them. We've got all of our other pediatric subspecialties represented, including pediatric urology as well. So let's talk a little bit about why we're here today. And we're here to learn more about hydrocephalus, which is a really important condition in children. And I know that it affects many of our lives. And we're really privileged and humbled that Dr. Daniels, who is the chief of our pediatric neurosurgery program, has really committed a significant part of his career to ensuring that we can provide the full care to kids who have hydrocephalus and to their families. And let me tell you a little bit about Dr. Daniels. So I met Dr. Daniels when I came here to Cape of Canadian Children's Hospital a little over 4 years ago. And I moved here from Philadelphia, and I was getting myself oriented to New Jersey, not quite sure where I had landed here, but I was really looking forward to the opportunity to get to know our physicians, our nurses, and our team members. And I still remember meeting Dr. Daniels and how blown away I was by his storytelling about his about making things relevant to families and children, and about the really cutting edge care that he aspired to provide to kids. Again, no matter what their background. And he understood firsthand some of the challenges that families were having, especially those families that were affected by children who have hydrocephalus. So I still remember some of my initial conversations with him and thinking, isn't it absolutely incredible that such a talented neurosurgeon who's been trained at the best facilities in the world has dedicated his entire career to serving our community and building the programs that we are building to take care of children here locally so that we can have outcomes that are comparable with any other children's hospital in the world. And isn't that an absolutely incredible situation? So over the years, as I've gotten to know Dr. Daniels more, my impression has only grown of his work. This is really God's work that he is doing here. And the programs that he is developing here, which include hydrocephalus, which include stroke and managing stroke in children, which you might think is an unusual scenario, but for us, it's it's becoming less unusual. And he has single-handedly decided and taken on the Herculean task of developing an approach to children who have strokes. So from making sure that our sister hospitals have the capabilities to recognize stroke in children, to ensuring that we have the protocols in place to be able to treat children who have stroke, because this is time-limited treatment. Obviously, you don't wait for a few hours in a patient that has stroke, either adult or a child. So he's really spearheading this effort, and I want to recognize the work that he's doing with stroke. Craniofacial. So we have Eileen Preenan, who is in the audience, who is our program manager for surgical services, and she also works very closely with Dr. Daniels and with our plastic surgeon, Dr. Gargano. But Dr. Daniels and Dr. Gargano and Eileen have built an amazing craniofacial program for kids who have these disorders. So they provide care to kids from all walks of life. They have a multidisciplinary team that manages these children, and I think that our reputation is growing in that area as well, and our craniofacial program is certified and recognized. So the programs that Dr. Daniels has developed within pediatric neurosurgery, I've given you a couple of examples of that, but you can see the spectrum of care that's being delivered here. He is also very interested in epilepsy, and as you may be aware, there are surgical treatment options for epilepsy as well. So it's important that we are able to provide life-changing care to kids who have really challenging epilepsy and seizure disorders as well. So I've had the opportunity to talk to patients of Dr. Daniels, and invariably all of them tell me one thing. Dr. Daniels takes care of children like they're his own family. He takes the time to listen, he takes the time to connect, he takes the time to make kids feel comfortable. And that's so important when you're dealing with children who may have, really significant problems. So I again am just so honored to be able to introduce this Hydrocephalus Symposium and have Dr. Daniels lead the sessions that you're going to be hearing. Again, I want to thank you all for coming to Cahill Canadian Children's Hospital, listening to our Zoom session, and learning with all of us about hydrocephalus and the care that we can provide. So thank you again. And with that, I'm going to pass it on to Dr. Daniels, our Chief of Pediatric Neurosurgery. Thank you.
Wow, it was a great introduction. Thank you, Dr. Parker. So I think that I was at a fundraiser the other day, and it's a fundraiser specifically for the Department of Neurosciences down here. And I was talking to the people at the fundraiser, and I was thanking them for their resources that they raise and dedicate to the neuroscience department here at the Jersey Shore. And I mentioned something to them, and I said that there's something special about the Jersey Shore. There's something in the soil. And what I meant by that is, if it were not for the administration in the Children's Hospital, for Dr. Paul, for Eileen, for Debbie, for my staff, my sister Sonny, for our patients, Carly, if it were not for the culture that surrounds us, all these different providers that we have coming from all over the country and doing all this amazing work here. Possible. So part of our goal with doing things like this is to give back and also give us an opportunity to celebrate one another and celebrate some of our accomplishments. And that's what we're going to do today. So, you know, I'm going to start off talking about hydrocephalus in children. And it's a great way to start. Hello. It's a great way to start because it kind of gives us a fundamental understanding of what hydrocephalus is and how it's evolved. And it sets up some of the other speakers. But this is fairly informal. So if anyone in the audience has any questions at any time, you can stop me and let me know, because we're here for you. We work for you. Our purpose is driven by us being able to educate you, communicate you, and serve you. And so the main goal of today is to celebrate our patients with hydrocephalus and their accomplishments and educate friends, family, and other physicians on some of the details of hydrocephalus to give us a better idea of how to identify it, how to treat it. And also make awareness in the area, because there are a lot of patients. And again, one of my patients right now who was taken care of by the person who trained me at Children's Hospital of Philadelphia. And I was the last person they trained. And this young man, because he had his work done at Children's Hospital of Philadelphia, when he got sick, the family would always go to Children's Hospital of Philadelphia. But this time he got so sick that he probably wasn't made it there. And we had to helicopter him into our hospital. And I had to intervene on him in the helicopter pad, right? And that saved his life. And that's the reason why we're here ultimately, because we're fairly new at this in terms of programs and doing this level of pediatric neurosurgery. But we need the community to know, so that people know that if something happens to their child, if we come out of the community. So without further ado, let me start my presentation. I'm being told that, oh, really quickly. Dan, do you have something to say?
Sure.
So before we get started, we have a parent of a patient on hydrocephalus that I actually want to speak and kind of help introduce everyone as well.
All right, good morning, everyone. How are you doing today?
Good morning. Good morning.
Right. So again, my name is Dan Lima. I'm a co-chair for the Jersey Shore Walk to End Hydrocephalus. This is my first year being a part of this, so I'm a little bit nervous, but happy to be here. First, some thank yous are in order. Without collaboration from patients, parents, caregivers, researchers, nurses, doctors, none of the benefits or the information from an event like today would be possible at all. So thank you to anyone who's here physically or via Zoom. Thanks. I'd like to thank the Hackensack Meridian Health Jersey Shore University Medical Center for hosting our symposium today. And I'd like to thank the impressive lineup of speakers that we have for you today, with expertise ranging from hydrocephalus in children, like Dr. Daniels said, to normal pressure hydrocephalus, commonly known as NPH, to the future of hydrocephalus. Also like to thank our COO from the Hydrocephalus Association, Amanda Garzon, for being here, and our also like to thank Dr. Daniels himself for being the tip of the spear and inviting us to be here today after 3 years without having this event due to different reasons. As some of you may know, the Hydrocephalus Association is celebrating their 40th anniversary this year. HA began as a parents support group in San Francisco in 1983 and is now the largest nonprofit, non-governmental funder of hydrocephalus research in the United States because of people like you that are here today. My connection to hydrocephalus and the beginning of my involvement with HA began 2 years ago, almost to the day after my youngest daughter, Holly, was born on September 3rd, 2021. Shortly after Holly's birth, her pediatrician, Dr. Angelo Palermo, noticed that her head size was abnormally large and continued to grow during our first weeks of checkups. You know, all the back and forth to the doctor's office. Everybody who has kids knows a lot of appointments. He referred us, our family, to meet with Dr. Luigi Pisani from Cooperman Barnabas Medical Center, where Holly was born. After our first meeting and Holly's first of many MRIs with Dr. Pisani, Holly was diagnosed with hydrocephalus as her brain ventricles were incredibly oversized. She was scheduled for brain surgery and placement of her VP shunt the following morning at exactly 3 weeks of age. And my journey and our family's journey into the world of hydrocephalus was on. It was officially underway. My wife Laura and I were overwhelmed, to say it mildly, after Holly's diagnosis and surgery. We spiraled into, Googling everything, reading all kinds of things and not really understanding what you're reading, not understanding or retaining any knowledge because we didn't really know anything. We hadn't heard about hydrocephalus ever. We had not known anyone with hydrocephalus. It was all just brand new. And it was scary. So through the following months, our stress levels and worries began to calm down a bit as our family visits with Dr. Pisani went on, and as Holly improved with, her health and her after surgery, and she's hitting all her milestones, and we're happy to say that she has had no issues since her shunt was placed 2 years ago. I remember looking into how our family can get, more involved with the hydrocephalus community, and that's how I found out about our walk in Jersey Shore. Last year was our first walk. We registered as a team for the first time, and we had a blast. We met other families, we met other people who were impacted by hydrocephalus the same way we are, which is great. It's great to just meet other people who know what you're going through because they're going through it also. It was a really emotional day. It was uplifting. It was a really good day on the boardwalk. And our first walk is also where I met Dr. Daniel's patient, Carly Weissman. Carly has been the chair or co-chair of the Jersey Shore Walk to End Hydrocephalus since its inception in this state 7 years ago. And I remember talking with her last year for the first time after the walk about her story and our family story, and Holly and her were taking pictures, and it was just a great thing. And I remember vividly saying to her, anything you need moving forward, just let me know. I'll help you out. No big deal. And about a week later, Carly contacted me and let me know that her co-chair that worked with her over the past couple of years was stepping down. And she had asked me to join with her and be her new co-chair. And that was it. Boom, done. Yep. Fast forward a year, we just had our Walk to End Hydrocephalus 2023 in Jersey Shore. It was this past Sunday at the Bradley Beach Boardwalk, right up the road. We had a blast. The only difference was it was a little rainy this year, and by a little I mean torrential, but it's okay. We had a good time and we had a great day for the community. I'm looking forward to many more successful events like our walk and today's symposium in the future. I'm really honored to be here and to share our story, and honored to be a part of this community. And I'll continue to do whatever I can to help find a cure for hydrocephalus and improve the lives of those who are impacted. In closing, I'd like to share just a small bit of advice that I've been given along the last year. I was at a conference in St. Louis chatting with another walk chair named Larry McKenzie from Buffalo. And he's been involved with the Hydrocephalus Association for, I think he said 12 or 13 years at this point. So I figured it would be a good person to talk to, pick his brain a little bit. I asked him for any hints or any, pointers on how to make as much as an impact as I personally could. He told me sometimes it's not about what you can personally do. It's more, listening to people, learning from other people, and maybe turn that into something, I guess, try not to do everything yourself. Listen, learn, work with other people, and just, it's not always about just what you can do. He told me to be a sponge, soak it up, learn everything you can, and that's what I'm trying to do. Thank you so much for having me, Dr. Daniels, and let's have a great day.
Okay. So look at the show me roll. Let me see if I can share the presentation. And let's start talking about hydrocephalus in children. Right, so what we're going to do during this talk is we're going to define hydrocephalus for individuals who are not familiar. And then I'm going to take us to medical school a little bit. We're going to talk about a little bit of neuroanatomy and physiology, specifically of cerebral spinal fluid, which is the fluid that the brain creates, which is, at the foundation of the diagnosis of hydrocephalus in children at least. And then we're going to discuss the pathophysiology of hydrocephalus. So what makes hydrocephalus a disease and how the disease operates in the body and causes problems and symptoms and sometimes even damage. And then we'll talk about the treatment. What do we do to try to mitigate some of the problems that are caused by hydrocephalus? So first, we're going to start off with defining hydrocephalus, getting to the anatomy, and then we're going to go into some of the causes of hydrocephalus as we talk about the pathophysiology. How do we diagnose it, and then how do we treat it, either with medicine or with surgery? So if you go online and you look up the definition of hydrocephalus on Google, you'll find something similar to this. And I'm going to read it verbatim. It says a condition in which fluid accumulates in the brain, typically in young children, enlarging the head and sometimes causing brain damage. Right? Hydrocephalus is the word, comes from the Greek, which hydro is water and cephalat as head. Right? So what does that mean from a neurological perspective and from a neuroanatomical and anatomical perspective, right? So there is a collection of chambers inside the brain called ventricles. Those are these blue chambers that are highlighted to the left. These ventricles are the place where the fluid that the brain creates naturally and the fluid that the spinal cord creates naturally is housed. And these red markings inside the ventricles are specialized capillaries, these specialized blood vessels that secrete the CSF, which the body uses to cleanse itself, but also uses to allow the brain to float inside the intracranial cavity or the skull. Now, with most individuals, as soon as we create this fluid, we reabsorb it. So there's always a balance in the fluid. In individuals who have hydrocephalus, there is a gross accumulation of this fluid because those individuals lose the ability to reabsorb some of that fluid. So again, this is another picture of the ventricular anatomy. This is looking at it from two different views. One view, the view on the left, is looking at it if you were looking at someone's face and then looking to the back of their head. And you'll see two ventricles here, which are called the lateral ventricles, that then have small passageways that communicate with another ventricle called the third ventricle, that has a small passageway that communicates with another ventricle called the fourth ventricle, down to the central canal, which goes to the spinal cord. And there are also other exit sites into a space called the subarachnoid space, which is a space where CSF is created and reabsorbed, and it surrounds the entire brain and the spinal cord. So this blue area outlined on the brain would be that subarachnoid space. These spaces are important. Ventricles are typically fairly small in a normal person, and most of the CSF that's in someone's body is usually located in the subarachnoid space. This is important because there's certain therapies that we can create to get access to that space to treat hydrocephalus. And I'll talk about that when we go into the treatment. Now, what are the causes of hydrocephalus? Well, There are many things that can cause hydrocephalus. There are many things that can cause this mismatch between the creation of CSF and the absorption of CSF. Typically, it's things that lead to a decrease in the absorption of CSF that leads to this mismatch, that leads to communication, that leads to hydrocephalus. The most common cause of hydrocephalus is something called an intraventricular hemorrhage. The hemorrhage is a bleed. Intraventricular means inside the ventricle, the chambers that we just discussed. Young babies, especially premature babies, whose brains are not as developed, have a weakness in an area called the subependymal area. It's the area just outside the ventricles. And so they can have bleeds in these areas, and these bleeds sometimes go inside the ventricle. When you get that blood in the ventricle, it can clog the natural passageways for CSF to be reabsorbed. And we could find ourselves in a situation where then the CSF accumulates. And if that happens in younger patients, then that pig can get larger and larger and larger, even to a point where it builds up pressure and it can squeeze the brain from the inside out and can start causing damage. Now, we'll talk about some of the other causes, like a myelomeningeal seal, which is the second most common cause of hydrocephalus in children. A myelomeningeal seal is a defect in development that occurs in the back, and it allows the nerves in the back to be exposed to the outside environment, which in a child that's being born and being developed is the amniotic sac or amniotic fluid, which is considered caustic or scarring to the central nervous system. So it causes prolonged exposure, causes scarring in the central nervous system and scarring in some of the areas where the CSF is reabsorbed. And we can lead to a situation where CSF then accumulates, and you can have a baby that begins having hydrocephalus even before the tumors. Tumors occurring in certain parts of the brain that might block the passageway from one ventricle to the next can lead to fluid building up in another ventricle. And if that happens, you can then get a person that accumulates fluid in a particular part of the brain, and that can lead to hydrocephalus, which is called a non-communicating hydrocephalus. Now, there's not many types of diseases that lead to an increase in production in CSF, which then leads to a mismatch in an accumulation of CSF. But there is one, which is a specific type of tumor that occurs in those specialized capillaries, the choroid plexus, that leads to an overproduction of CSF. And that's a mechanism by which a tumor can actually lead to an overproduction of CSF, and it can cause hydrocephalus. Sometimes people are born with the natural closure of one of the passageways that allows the third ventricle to communicate with the fourth ventricle. It's called aqueductal stenosis. If that happens, then you can get a buildup in the CSF in the lateral ventricles and the third ventricle as they try to exit down to the fourth ventricle. Then infections, head injuries. These types also occur in adults, and we're going to get more discussion about this later. But these are some of the other causes of hydrocephalus. Now, if you take those causes into consideration, you know, you're approaching 80% of the causes of hydrocephalus. Now, what are the signs and symptoms of hydrocephalus? This is when we're going to get to we're approaching diagnosis. We'll be discussing these things. But this is also very important for family members who might have loved ones who are afflicted with hydrocephalus, and for some of our older patients who might begin to understand themselves what are some of the things that they might be experiencing that would let them know that they have their hydrocephalus not being treated, maybe because their shunts not working as well. But when you think about the signs and symptoms of hydrocephalus, you really have to think about the age of the patient, namely because not so much because the different types of hydrocephalus are caused by different things, but because in patients that are younger than 2 years of age, their skulls are not completely formed and fused. When you think about it, whenever you have your cousins and your relatives that have a baby, feel on their head. Don't feel too hard, but feel on their head, and you'll feel soft spots. Those are areas of the skull that are not completely fused with bone. And the reason why that occurs is because babies' brains grow to 80% the size of an adult brain by 2.5 years of age. And if their skulls were fixed like ours, it wouldn't be able to grow fast enough to accommodate for the natural growth of the brain. As a result of that, babies' brains and skulls are really malleable, meaning they can really stretch. So one of the first things we look for, if any of you guys remember having a loved one with a young patient and you're going to see a doctor, what are one of the things that doctors do before the age of 2 in almost all their patients? They check their head circumference. They get a little measuring tape, they put the measuring tape around the head, and they check their head circumference. And the reason why they do that is because if these babies are accumulating volume accumulating fluid, accumulating volume, then their skulls get larger and larger. And that's one of the things that we see when someone has hydrocephalus. So it's an increase in head size. These sutures, which are the separations between the different places of the skull in younger patients, they can also get larger and they can get splayed, and the spaces between them become more pronounced. That can also be a sign that a patient's accumulating fluid in their skull faster than the normal growth of the brain, and that might be a sign of hydrocephalus. This soft spot that babies have, when my students are in the room, and some of my students have already done a lot of studying with hydrocephalus, and so I tell them that whenever they have a new baby in the family, to kind of like sneak a peek and feel on the head, and specifically feel what's called the anterior fontanelle, which is that soft spot, because that's like what we call an ICP monitor, an intracranial pressure monitor. If you get really, really good at it, you can feel a baby's head and get an idea of whether the fontanelle is full or whether it's tense, and whether there's an increase in pressure inside the skull or not, which could be an indication of the buildup of fluid. Now, when the fluid accumulates so much that it might begin exerting pressure on certain parts of the brain, then you'll start eliciting certain abnormalities in the brain function. But when you're dealing with really, really small babies who are not talking, not walking, can't really communicate whether they have numbness or weakness somewhere, you oftentimes have to rely on reflexes to give you an indication whether the brain is suffering. So some of those reflexes are very simple things like breathing and controlling the heart rate. So sometimes babies can have apneic episodes where they're not breathing as readily or as regularly, or their heart rates can decrease. And these could be signs that pressure is accumulating in babies and that they might have hydrocephalus. Once you start getting to these last two signs, it becomes an issue. You need to see a doctor or go to an emergency room because there might be an emergent intervention that's necessary in order to treat the patient. And the last is global decrease in activity. Ultimately, what's happening is the fluid's accumulating so much that it's squeezing the brain from the inside out. It is actually putting the brain to sleep. It's decreasing the activity of the brain. We typically don't see these things at home because by that time patients are typically in a hospital. But these are some of the ominous signs of hydrocephalus in younger patients. These are some of the things where intervention is required. Physical exam findings, right? Now, but what we discussed before for the doctors and future doctors and our audience, what we discussed before are the things that patients usually present to us. Now we're going to talk about the things that we measure as physicians on the physical examination. One thing is measuring the head circumference, and then we have charts where we can take an individual's head circumference, compare it to head circumferences from thousands of other patients to give us an indication of what's normal and what's not normal. We can follow these head circumferences. We can take a growth chart. It gives us an indication that someone's head's also growing abnormally fast. And these are some of the things that we look for to give us an indication that someone has hydrocephalus. In addition to that, we can have, again, disjuncture sutures, which is something that you can feel when you palpate the patient's skull. Something else that I'll show you a picture of momentarily is dilated veins, right? Sometimes babies don't have a lot of hair. And as a result of that, you can see the veins in their scalp. The veins in their scalp communicate with the veins inside their brain, which are called the sinuses. And if you have a buildup of pressure inside the brain, which might disturb the flow of fluid from the brain back to the heart, then you can also get a buildup of these scalp vessels because the scalp vessels try to take over some of the work that the vessels in the brain are supposed to do, but by sending blood back to the heart through the scalp. There's something else called sunsetting phenomena, where the part of the brain that's responsible for one's ability to lift their eyes up to look up is being compressed from the pressure associated with the accumulation of fluid. And if that happens, you can get something called sunsetting eyes, where the eyes drop down because the patient doesn't have the ability to lift their eyes. It's called pronounced phenomenon. And that's also an indication that the pressure is building up so much that it's beginning to affect the brain and potentially putting the brain at risk of being damaged. So this is an example of a child with a large head, right? And with the vessels that are engorged, that are enlarged in the scalp. So for the physicians, for family members, this is an extreme case. This is the type of stuff you get on the internet, right? So a lot of times we have parents look to Dr. Google and try to get an answer what's going on, and they're terrified. Well, that's because on the internet, you get the extreme cases. and you show the extreme cases to prove the point. But I don't want you guys to get caught up on this picture. This is a rare phenomenon. And some of the other pictures we're showing as well, these pictures are typically pictures we see in developing nations that don't have developed medical systems. And so these are patients that are not necessarily captured as soon as maybe what would happen in our system. But this is just to illustrate this phenomenon, right? This pathological phenomenon of pressure being built up in the skull, leading to veins in the scalp having to take over some of the responsibility of draining the blood from the brain. This is an example of a child who's not lifting their eyeballs, right? Who has that paralysis, and the muscles that are responsible for lifting the eyeballs because they're having pressure and on the tectal plate or part of the brain where this function is located, right? So that's an example of sunsetting eyes. And then this is an example of something called megahydrocephalus. And I showed this picture to give everyone an idea of the capacity of the skull to expand, right, in young age. So this is a patient who's around 2 to 3 years of age, whose sutures have never had an opportunity to close because the patient was accumulating CSF. Not so much that it was exerting a tremendous amount of pressure on the brain, right? But enough that it wasn't allowing the brain's skull to close. And as a result of that, that slow accumulation of fluid allows the skull to get larger and larger and larger. And this, we have skulls that get 2 or 3 times the size of this as well in some patients. Now, so in terms of diagnosing patients who have hydrocephalus with a non-fixed skull, we use these things. But when someone's skull is fixed, meaning when we're dealing with patients that are above 2.5 years of age, and their skulls don't have that capacity to expand as rapidly, then what we ultimately end up getting when we get the accumulation of fluid is an increase in pressure. And so the phenomenon of hydrocephalus manifests in terms of increase in pressure, which can be caused by, that's what a bulging fontanelle looks like. And like I said, that could be a natural ICP monitor in a patient without a fixed skull. And then this is the hair circumference charts. And you can see these different lines indicate what 50th percentile, 80th percentile, 90th percentile should be. And you can measure someone's head circumference every time you visit them. You get an idea whether they're growing at a normal rate or whether they're going from one percentile to another, which is an indication that they're growing so fast. Now, when the skull is fixed, the symptoms that patients present with are symptoms that are related to increased intracranial pressure, increased pressure inside the skull, which would be headaches, nausea, vomiting, double vision, because sometimes it could be so much pressure in the skull that the skull can then be forced downward towards the exit of the skull, where the skull meets the spinal cord. And there are nerves that are located in that region, specifically the 6th cranial nerve, that can be then crushed and compromised. It can lead to weakness in the function of the 6th cranial nerve, which assists moving the eyes. And so because the eyes are not moving coordinatedly, you'll get double vision. And then again, because accumulation of fluid leading to pressure is the more common mechanism of causing problems with hydrocephalus with fixed skull, then you'll get that global deficit that you see patients getting sleepy, decreasing their activity because essentially the brain's being turned off and they're going into a coma. There's going to be, I'm going to swipe to you really quickly because these are some of the things that the neurosurgeon is going to talk about when we talk about hydrocephalus in adult patients. But just really quickly, there are other things that we can find in the physical exam, like papilledema, where we can have an ophthalmologist look in the eyes and we can see the manifestation of that pressure in the eyes. Because the part of the eye, which is the optic sheath and the optic nerve, communicate with the brain. So when you get an accumulation of fluid in the brain and pressure, that accumulation of fluid then manifests in the optic nerve, and it can lead to something called papilledema. And this is a picture of the cranial nerves, and this nerve down here that I'm pointing to is a 6th cranial nerve, and you can see in between it, the brainstem, which is brain and bone, is located this nerve. So when the pressure builds up in the head and everything is pushed down through the foramen magnum, or the hole in the bottom of the head, it can press on that nerve, and it can lead to a dysfunction of that nerve. And as a result, when someone looks to one side, that nerve that's supposed to pull the eye to that side doesn't work. Right, so here you have someone looking to their left, and both eyes are looking to the left, And then you have this person looking to the right, and the one eye where the sixth cranial nerve is being compressed doesn't move. And that's it for the physicians in the audience, and the future physicians specifically, that's an exam that you could perform to give you an indication that someone has high pressures, so much so that the brain is being forced down to the foramen magnum and is crushing the system. Right, imaging studies. Right, so a hallmark on us sorting out whether someone has hydrocephalus or not is looking inside the brain, and specifically looking at the area called the ventricles and getting an idea whether the ventricles are larger. Now, in younger patients who have an open fontanelle, meaning they don't have bone in the front of their head, we can stick an ultrasound probe in there. And because they don't have bones, we can use sonographic energy to look inside the skull and then look and see what the ventricles look like. So that's the picture to the left, and measure the size of the ventricles. Once the skull is fixed, the ultrasound, the sound waves can't get through the skull. And as a result of that, we have to rely on CT scans, which are sophisticated machines that shoot X-rays and then pick up the result of the X-rays on the computer. Then the computer takes it and turns it into a 3D representation of the inside of the skull. And we can see here that the ventricles, these dark areas where the fluid is contained, are larger than normal. And in addition to that, there's fluid being pushed out just adjacent to the ventricle, which is an indication that there's increased hydrostatic pressure caused by water inside the ventricles and inside the hydrocephalus. And then the last one is an MRI. And an MRI is a way that we can get a picture of the brain, not necessarily using X-rays, but using energy created by a magnet and detecting the result of that energy from some of the cells and some of the neutrons in the cell. But it gives us another black and white picture with far more detailed anatomy. And it can give us an indication whether fluid's building up because the ventricles are larger, and whether there's fluid on the outside of the ventricles indicating to us that there's pressure. Another way that we can diagnose hydrocephalus is by sticking a needle in the spine, getting access to the subarachnoid space, right, where that CSF fluid is located, not necessarily in the brain, but lower below, and then measuring that pressure. And we can get an idea whether that pressure is abnormally large and give us an indication whether someone's suffering from hydrocephalus. Another way for us to diagnose hydrocephalus, remember, with most patients, hydrocephalus causes symptoms when the pressures increase. And sometimes we'll look at someone's CT scan, like Carly's CT scans, don't necessarily tell you whether she has hydrocephalus or not, because her ventricles don't necessarily get larger, right? And so sometimes what we have to do, and we have to do this for Carly, this is one of Carly's many surgeries, is we have to put a monitor in there, and we have to measure whether the pressures increase. Which even if the ventricles haven't gotten larger, the CT scan doesn't give us enough information, that pressure increase in someone with hydrocephalus could be an indication that their shunt's not working, right? Or their shunt's not working as well as it should. And we need to give them a little bit more support, maybe by designing a new type of shunt system and using a new type of shunt. Now, treatment of hydrocephalus. There's some patients, and one of our doctors will talk about this with another form of hydrocephalus. It's controversial as to whether this really represents hydrocephalus or not. Something called pseudotumor cerebri. When the mainstays of treating patients with that type of accumulation of fluid is giving them a medication. In an acute setting, when someone's having life-threatening hydrocephalus, I could typically give something called steroids, which typically help with the symptoms. And we don't necessarily understand why, but it's not necessarily a mainstay therapy. It's not something you can keep someone on, but it's a way for you to keep them comfortable. When people are in pain, they can clutch up, they tend to flex their abdomens, their heart rates tend to increase, their blood pressures increase. All these things increase the pressure in the brain, right? And if you're dealing with a situation where someone's on the verge of having a catastrophic event because of increased pressure, and it's going to take you time to intervene, then you can give them steroids sometimes that it decreases the pain, and it can decrease some of those other secondary mechanisms that might decrease the pressure. And then there's other medications like diuretics. Diamox is one diuretic, which we know decreases their production of CSF. And sometimes we can put patients on this long term, especially if they're having the type of hydrocephalus that doesn't really involve a chronic accumulation of fluid that builds up, and that we might maybe be able to address a small mismatch in some of those patients. But the mainstay of treating hydrocephalus is shunting at this point, right? A device that we put inside the ventricles where the fluid's building up. And then as the fluid builds up, it allows the fluid to escape, and then we can put it somewhere else in the body. Typically, the distal part of the shunt, the part of the shunt that goes from the skull and the brain to somewhere else, usually is put in the abdomen, in the peritoneal space, where we had this huge sheet of fat called omentum. And that omentum absorbs the CSF and incorporates it back in the body. Sometimes we can put it in the lungs because sometimes patients have issues in their abdomen, or really young patients don't have the capacity to absorb it in their abdomen. We can slip it in their peritoneal space and it can be absorbed with the peritoneal fluid. The most physiological, but sometimes the most risky way to place a shunt is to put it in a vein that leads to the heart. So the fluid goes back to the venous system, which is the natural way that CSF is reabsorbed inside the brain. So the mechanics of a shunt is there is a proximal catheter that goes into the brain, into the ventricles to drain the fluid. And then there's usually a reservoir, which is a mechanism that regulates the flow, either by setting a pressure limit and indicating that a patient only drains when their pressure exceeds in a certain amount, or in some settings by creating flow irrespective of the pressure, but then restricting the flow to a certain amount so that patients don't overdrain, which could be a problem with patients with shunts. And then there's a distal catheter that connects to that reservoir and goes to another part of the body. Now, there's an alternative to putting in a shunt, and it's something called an endoscopic third ventriculostomy. And what this is a procedure where physicians use a small stylet with a light source attached to it and a camera attached to it that we can then tunnel specifically to the spot in the third ventricle that we can create a hole in that then opens up the third ventricle and gives it access to the subarachnoid space. And remember, especially in adults, because the spinal cord is so long, there's actually more capacity for fluid absorption because of the greater surface area in the subarachnoid space than there are in the ventricles. So if we can reroute the fluid, either because the fluid's being blocked somewhere, or we're just not truly getting access to that draining capacity in the subarachnoid space, then we can stick an endoscope inside the ventricles, slide down what's called the foramen row. Dr. Pananak and I just did one of these a couple of months ago. And then open up the floor of the third ventricle, create a hole in that area, and allow the fluid to flow from the ventricles into the subarachnoid space. Right, this is a picture of it. Now we're going to cross our fingers and hope the video works. But this is a video of it. Right, so far so good. So now we're sliding down into the ventricle. So we just slid through the brain. We're in the lateral ventricle. We're going to the foramen row, and now we're in the third ventricle. And then at the bottom of the third ventricle, you can see this lucent, almost sheer looking area, right? That's the part of the brain that if we pop a hole in, which you'll see when we do this video from Brazil. Tatiana might even know the surgeons who are doing this, one of our speakers from Brazil. And then we're going to put a balloon in there. We're going to expand that hole because what we don't want to do is for that hole to scar down and close itself. And although it looks ginormous now, that hole is the size of a pin, right? A ballpoint pen. And then we'll inflate it, make it a little bit larger. Right now, they're coagulating the hole. And they're going to stick what's called a Fogarty balloon in there. And they're going to put that balloon at the right place to try to expand that hole. And then you'll see that area pulsate because there's fluid flowing in and out of that area. So we rerouted the fluid from the ventricles to try to have that fluid go to the subarachnoid space to get access to that draining capacity in the surface. After this video, it's the end of the presentation. So while we're looking at this, does anyone have any questions? Don't hesitate, Victoria. Yes.
Dr. Daniels, how often, like when you're going through the process of deciding if you're going to do an ETV versus a shunt, what is that process for you when you're evaluating a patient? And what percentage of ETVs do you do to shunts now in your practice?
It's a good question. So I'll tell you a story. There's the chief of neurosurgery at Children's Hospital in Philadelphia is named Dr. J. Storm. And there was a time when we first began getting comfortable with this technology. So we're talking about maybe 10, 15 years back. A lot of neurosurgeons were running to doing ETVs on patients. And the reason why they were doing that is because shunts, although we save so many lives with shunts have a really high failure rate. Because imagine what the body does to something that's foreign and you try to keep it working in the body for someone's lifetime, right? The body begins to put calcium inside of it, it makes it brittle, it makes it friable, it makes it break. There's scar tissue that forms on the shunt. 60% of shunts at the age of, at 5 years out from the shunt are usually not working anymore, and the patient requires some type of revision. So if you're at a place at Children's Hospital in Philadelphia that does maybe 1,200 cases a year, about after a certain amount of time, about 40 to 60% of your cases are all shunt related. And so he was so wanting to get rid of that, he would be doing ETVs on everyone, right? And it's also those efforts from other individuals that really gave us an understanding of which type of individuals will fare well with ETVs. And the way that I look at it is, if you have patients that have a lot of inflammation, meaning if you have patients that have a meningitis and maybe hydrocephalus from a meningitis, they're probably not the best candidates. If you have patients that are really, really young patients' brains grow so quickly, and young patients heal so well from scarring. And what I mean by young is like newborns. We know that ETVs don't really work well in those patients they fail. And a lot of times we think they fail because those holes that we create, they close, right? So there are the right type of patients to perform it on. And a lot of times what we'll get patients who didn't have the luxury of affording an ETV either because they were really, really young at the time, or they had other type of factors that decrease the risk of a death for an ETV. They have a shunt, that shunt malfunctions, and now the ETV is a possibility, right? And you might give it a shot to help patients out. But on older patients with an obstructive hydrocephalus, a blockage like an aqueductal stenosis or something like that, or a blockage from the tumor, those patients actually do really, really well.
Yes.
Why did ETV not work for all hydrocephalus patients?
So yeah, that's precisely it. Well, one, we know some people have hydrocephalus, but we don't necessarily know on an individual basis, or at least not yet. And I'm going to talk about some of the technology that might get us to this. But we never really know exactly what that mismatch is for any individual person. And so some people might have a mismatch that's so subtle that rerouting their fluid to another space in the brain might be enough to compensate for this mismatch, and they don't accumulate fluid. Some people it might be too significant. In some other cases, depending on if you're dealing with really, really young patients or patients who are set up to scar very easily, you might create that hole, but that hole might then close by itself. There's a patient that Panagna and I was actually considered doing an ETV on. It was a patient with a tumor, but the patient had chronic hydrocephalus. And as a result of that, their ventricles got really, really large, including the third ventricle, which began to bow into what's called the basal cistern, right, which is where we pop that hole in. And so it makes it more dangerous because there's an extremely important artery there called the basilar artery that can be injured during the surgery. And the deeper you have to go into that basal cistern, the more risk you put that artery at. But in addition to that, once you create that hole, there's a significant amount of redundancy in that tissue. So as that tissue is flopping, the tissue can touch, right? And if there's not a significant amount of fluid going through that route, maybe because that patient doesn't have a significant requirement of fluid that needs to be rerouted out of the ventricles, then it can close. Any other questions?
Can the ETV be repeated?
You typically would not, you probably, I mean, you can. That would be a surgeon that really, really hates shunts. But if you have something that's already failed and you're concerned that, it might fail again, everything that we do has risks associated with it. And you're always weighing the risk of what you're doing to the benefit of it. So if you have an ETV that's already failed, I would be less inclined to try it again when you have a less risky procedure, albeit you don't rid them of the device their whole life, but you can treat them really, really well with the shunt. Yeah,
for babies with hydrocephalus that maybe it's not identified that early and their head size kind of grows a lot, is it still able for the skull to return back to a normal size after it's treated?
That's a good question. So in some cases, yes. It really depends. So the other factors that I think contribute to that, there's something called compliance, which is how readily ventricles are to shrink given various different pressures. And depending on the cause of hydrocephalus, someone's compliance might be affected, and as a result of that, the ventricles don't change much in size. So the ventricles might remain the same size, but the brain is still going to grow. So you'll have a head that's larger. But if you catch it early enough, you can create a situation most of the time that the body catches up with the head, right? And you might be dealing with a situation where you have a little bit of microcephaly, but it's not really noticeable, right? It's still within the range of movement.
With more questions from our online audience, if you want to clear this up.
Yeah, it's not
And if you guys can repeat them so the back of the room can hear, we're not hearing the questions always.
I don't think I can access the question, let me.
In the Q and A. Ready.
Right here, okay. Ready? Yeah. All right, so first question, can third ventriculostomies be done after a person has had a shunt for 30 years? Yes, it can be attempted. Would you only do this if the shunt is malfunction? Not necessarily. Carly and I. Well, a couple times. So there's risk associated with removing a shunt that's working. And these risks, what most neurosurgeons do, most of our patients do really, really well, and these risks don't manifest, but sometimes they do in rare occasions. And a lot of times they're out of our control. So we always have to be cautious about being in a situation where a patient has a system that's working well for them, and then doing something for the benefit of maybe doing it prophylactically, like trying to remove your shunt and giving you an ETV just so that you don't want to have a shunt. I tend to shy away from that, because if we do something that doesn't work and we have to put another shunt in, or if we create a situation where you get a complication from removing your shunt, I haven't helped you, right? And you were already in a place where you were doing well. But with that being said, and I always say this to my patients, I work for you. So if you sit down with your neurosurgeon, you can have that conversation, and both of you guys come to a conclusion that you're willing to take that risk, then yeah, that's something that some people would try. Question, it seems there is a tough transition from child to adult hydrocephalus care. Most specialists are pediatrics, and I'm in my 40s, and I now struggle to find hydrocephalus specialists. Any resources to help? That is a great question. Some of the technology that we've developed to take care of congenital phenomena is actually fairly new in society, right? The modern shunts were readily available in the 60s, right, and 70s. So what does it mean then to take care of these patients when they become adults? And this is something that we're aware of. We're aware of it in congenital heart disease. We're aware of it with congenital matters in neurosurgery. Everyone approaches it differently. This is not something we've been wrestling with as a community of physicians for a long period of time. But as neurosurgery becomes more specialized, adult neurosurgeons are becoming more and more uncomfortable dealing with congenital disease processes. And the type of hydrocephalus that an adult have is very different than the type of hydrocephalus that a pediatric patient has, and the type of hydrocephalus that someone whose bodies had to accommodate a shunt that's been dealing with for a long period of time. I take care of adults and pediatric patients. I'm really stingy about my patients, and I'm really hands-on about my patients. So I take care of patients, at all ages, and I do that specifically because my patients who are younger, I want to continue to take care of them because it's so difficult and so complicated. At this level, it's such an art form, and you really need to know that patient in order, I think, to make the best decisions for that patient, or if you're kind of starting all over in terms of what you're learning. There are other doctors who do the same thing. And what I would say is try to find some of those doctors. Unfortunately, some of the largest centers that take care of pediatric patients, they don't do that, right? And maybe it's difficult, right? Having a 40-year-old in the ICU in Children's Hospital of Philadelphia. And as a result of that, they don't go to the adult hospital. And as a result of that, there is this junction, so it's a problem. But a lot of times you can find pediatric neurosurgeons that are sensitive to this. And keep in mind, pediatric neurosurgeons train 7 years to do neurosurgery and 1 year to do pediatric neurosurgery. And so hopefully they continue to maintain their skill set in treating adults, and so they should be able to manage this. Next question, which are the outcomes expected after a shunt or ETV? In your experience, do you notice good improvements? Absolutely. These are great techniques that are used to treat this phenomenon. So we can't guarantee this, but we expect to be able to treat your hydrocephalus and alleviate your symptoms. It might take some time, especially when people are transitioning between being a child with hydrocephalus and an adult with hydrocephalus, who might have a shunt for their whole life, and then all of a sudden the shunt's not working as well. And now you're trying to figure out what their new requirements are, right? Do they need the same requirements for draining as they did when they were younger? Or have they regained some of their ability to drain their own fluid? And now what's their new normal? Fortunately, we have devices now that have magnets attached to them that allow us to program and change the setting on shunts without having to put someone through surgery. So then we can play with their numbers and the pressure thresholds to try to, and we also have so much more sophisticated valves that regulate shunts and regulate flow in different ways, that we can try to give them a shunt that's unique to their needs. My child, I'm gonna answer one more question. And then I'm gonna answer these last two questions and then we'll move on to regular behind. My child had to have an emergency shunt repair and due to increased pressure, at one point, would he have to have an ETV instead? It really all depends, and he's a candidate for ETV. But this is important. If you have a place that has any neurosurgeon and you have an emergency shunt malfunction, meaning someone's having symptoms that you think have a shunt malfunction, go to that ER. Don't necessarily try to make it to your doctor, because any neurosurgeon should be able to troubleshoot a shunt to save that individual's life. And an emergency setting might not be the best setting to do an ETV, because sometimes people get so sick that you have to relieve the pressure, and you're eager to see if you relieving the pressure is going to make them improve. And what you don't want to do is do an ETV where you're not certain it's working. So you might just go with putting in a shunt that you can test whether there's flow in that shunt before you completely internalize it in the patient. Part of the reason why we do this symposium is because we know it's predictable based upon epidemiological data in our population in Oceanside County, how many patients have shunts, right? But we've only been doing this work at this level for 4 or 5 years. So there's a lot of patients who had shunts that we didn't take care of, but they're in our community. But we know, and we've had this experience, they won't necessarily make it back to the hospital where they had their shunts done. And we want to create awareness in the community so that you know if you're having a shunt emergency, or if you think you're having a shunt emergency, you can come here, right? And we can save your life. And if that means afterwards sending you to your doctor so that you can get definitive treatment, then so be it. But I don't want people thinking they have to drive all the way to Philadelphia or drive to New York or drive to Hopkins if they have a shunt problem, because it can be life or death for some of these patients. Then the last question, what are the signs to look out for VP shunt malfunction if the patient comes to the ER? This is the ER for this letter, you can tell. So, or this is more than likely a resident that's probably going to start in the ER. So like we talked about, right? It could be as simple as a headache. And the experts, the people who are experts at this are going to be the family members and the patients in the audience, because they know what a shunt headache feels like, right? And so if you have a patient comes in and they have a headache and they have a shunt, listen to the family, right? They're experts at their symptomatology and they're experts at some of the uniqueness that are associated with their shunt. And then you do your standard workup. You check and see if there's any evidence of breakage of the shunt. You get a CT scan. Hopefully in the future, you put a wearable device on, and that device can indicate to you the flow of the shunt, and maybe even in the future, indicate to you whether that flow is optimal and normal or not. And maybe even, and I know I'm putting a lot on one of the companies we'll talk about later, maybe even be able to predict to you when the shunt's at risk of failure. Right? That's where the technology is headed. But do your workup. And if a patient is having nausea, vomiting, that means that a part of the brain called the area postrema is being compromised and irritated from the accumulation of the pressure. If a patient has abnormalities in their neurological exam, that means that a part of the brain is being put to sleep or is being injured. That's another increased severity. And if a patient is sleepy and lethargic, it is a life-threatening phenomenon, right? And you call the neurosurgeons first, have the neurosurgeons come down, because they might have to do, even with the neurosurgical PAs, an emergency intervention to relieve the pressure until we can sort out what's going on. Any other questions from the audience? Thank you. Time for our next speaker. So the next speaker we have is a pediatric neurosurgeon out of Brazil. She's an outstanding pediatric neurosurgeon. We first met when we were like young puppies, getting ready to finish neurosurgery and do our training in pediatric surgery. But she's an outstanding neurosurgeon. I'm really proud of her. I'm great to see her. I haven't seen her since COVID because we stopped doing our international visits. But her name is Dr. Tatiana Zinsko, and she's going to talk to us about a phenomenon called pseudotumor cerebri.
Hi, everybody. Can you hear it?
Yes.
Yes.
Okay, so hi, everybody. Good morning. I am really glad to be here. So I know Dr. Daniels for a long time when we were neurosurgeon, pediatric neurosurgeon fellowships. But I'm not going to say when, because this can reveal my age. So Lawrence, thanks a lot for the invitation. I'm really glad to share our experience in Brazil. We have a lot of cases of hydrocephalus, but I'm going to talk about a challenge disease, which is pseudotumor cerebri. So pseudotumor cerebri is a term that was proposed in 1904 by Noon, that explains a series of signs and symptoms that reflects increased intracranial pressure, but with a normal brain parenchyma. So we don't have space occupying lesion, ventriculomegaly, malignancy, or infection. So just this definition shows us that it's a really challenging disease because we have intracranial hypertension, but not a lesion directly seen to resect. And another term that I actually prefer to say is idiopathic intracranial hypertension. So I'm going to say IIH. And the newest term that was proposed was benign intracranial hypertension, but this was not really well accepted between neurologists and neurosurgeons because it is not benign when we have a disease that can decrease quality of life. So I prefer to say IIH. So how about a little bit of epidemiology? The annual prevalence in adults is at 0.9 to 2.3 per 100,000 people. And I am a pediatric neurosurgeon, so I'm going to say a little bit what happened in adults and what happened in children. So in the pediatric population, the prevalence is lower at 0.6 to 0.7 per 100,000, but the typical patient is the adult patient, the obese female of childbearing age, which shows us that probably is related to puberty and obesity and hormonal changes. But in the pediatric population, this is different. Young children have an equal distribution between gender, and actually boys below 12 years old, they are thinner. And after 12 years old, that obesity seems to be a risk. So the history that we hear a lot is a patient with obesity or recent weight gain, or a female with polycystic ovarian syndrome with a family history. But we have to keep in mind the secondary causes of IIH, because in children, 20 to 30% of the children will have secondary causes, and to treat well, we have to make this correct diagnosis. So some secondary causes are medical drugs, for example, tetracycline class antibiotics, or associated conditions in metabolic disease or genetic diseases. And in the vascular disease, it's really important to perform the study of the venous sinus to see if there is a thrombosis, and that the treatment is completely different. So secondary causes we have to keep this in mind. When we talk about pathophysiology, this is really unclear and controversial. So Dr. Daniels showed you how CSF is produced and how it is absorbed. And there is a lot of theories around IIH. So some theories say that is a overproduction, so this will cause accumulation. But we know from other models, for example, in choroid plexus papilloma or choroid plexus hyperplasia, we have an overproduction of CSF, but we have ventriculomegaly and hydrocephalus, which is completely different from IIH, because in IIH, we have normal size or decreased size ventricles. Problems in absorption. So we know that CSF is absorbed by choroid villi in the vessels. So there is a more recent theory that venous stenosis causes higher pressure in the vein, so the absorption of CSF will decrease. The question is intracranial hypertension causing compression of the sinus, making the stenosis, or is stenosis making difficulty of absorption causing intracranial hypertension? So this is already, this is still in study. Some in the end, I will talk about some studies that show stents to be used in this stenosis, but we still don't know what is the main cause. What we know is that when we perform in some patients drainage, lumbar drainage, we can see that the stenosis goes away. So in some patients, maybe stenosis is causing a problem in absorption, but not in all of the cases. Another thing is that we don't have only production and absorption. We know nowadays that CSF runs away in the parenchyma by these channels. So aquaporin 4 that perform transportation of CSF and aquaporin 1 that perform production of CSF. It seems that vitamin A can stimulate aquaporin 1, and we know that in IIH, people with IIH may have serum levels higher of vitamin A, but this is also still in study. What we know is that obesity and women in childbearing age are related to IIH, but so probably we have inflammation because the obesity has a link with interleukins and cytokines. So probably inflammation has a role in this pathophysiology. And when we talk about hormones, probably we have some difference in women, but we don't have a profile to date. We don't have a profile in IIH of an hormone profile. And it seems that also C-type natriuretic peptide is lower in people with IIH, and it happens also in endovascular disease, and this has a link in inflammation as it does in obesity. So we have a lot of work, a lot of studies to do, and the understanding this pathophysiology can help us at the end to treat these patients. And more recently, we had the COVID time, the COVID pandemic time. And we have a lot of publications showing that IIH raised in this pandemic time, especially in children. We have a lot of boys that are not overweight that had IIH. And the other theory is the problems in the lymphatic system, which is the lymphatic system of the brain. And we know nowadays that around the olfactory nerve, we can have absorption of CSF. So we don't know if during COVID, the lesion in this area, because people had problems in the olfactory nerve, if this can be related to IIH. So a lot of research is still to do, but what is important to treat is to perform the correct diagnosis. So the clinical presentation is really varies a lot, but we know by the IIH treatment trial that headache is the most important symptoms presented in 85% of the cases, and what we can expect from patients who have intracranial hypertension is what there is that when they lay down, headache will be worse. But obviously, it's not like that. headache varies a lot, maybe a migraine type or a tension type headache. So it's really hard to say that there is a direct relationship. So it's a package deal. We have to see a lot of symptoms and signs to make the diagnosis. The second most important symptom is transient obscuration of vision that happen in 6-8% of the patients, and it can last seconds at a time, but sometimes loss of visual acuity or visual field can be present, and this is the most feared complication. Of course, this happens in a long-term disease, but in the IIH treatment trial, they say that 32% of patients presented with these symptoms. So probably this is related with the challenging diagnosis. The third clinical symptom is back pain, and followed by pulsatile tinnitus, that the patient can really listen the sound of water passing, but this is subjective. Also, dizziness, photophobia, nocturia are signs that can be present, but it varies a lot. So because of this, in 2013, Deborah Friedman published the diagnosis criteria for IIH. And this is really important because there is a division between two groups of patients, one group with papilledema and another group without papilledema. So what are the criteria to make the diagnostic? So if the patient have papilledema, we have to have a normal neurological exam, except for cranial nerve abnormalities, as Dr. Daniel showed about the sixth nerve palsy. Also, the brain imaging show only signs of IIH, that I will talk about this later, and the lumbar puncture opening pressure in adults more than 250 millimeters, and in children more than 280, 250 only if the child is not sedated or if the child is overweight. And the CSF must be normal. But if the patient doesn't present papilledema, we will look at all the other criteria and the nerve palsy, sixth nerve palsy, uni or bilateral. And if this is normal, if the patient doesn't have sixth nerve palsy, so the imaging criteria will need to be present in 3 or 4. The empty cella, flattening of posterior aspect of the globe, distension of the periodic subarachnoid space, and the transverse venous sinus stenosis, which is the best predictor. And all of these has a specificity of 95%. And the question is the same thing in adults and in children, as the presentation is different, as the pathophysiology may be different, but the signs and symptoms are the same. Okay, so we have more than 95% of the specificity of the signs and symptoms for children and adults. What is different in children is the papilledema, as Dr. Daniel showed. So papilledema will be seen in fundoscopy, but in children, we can have elevated optic discs. And so there is a condition called pseudopapilledema. So it is important to make this difference. So when we see the borders of the optic nerve, and when we see this trifurcation of the vessels, so in this case, we have to perform another exams to confirm papilledema. So we have to perform the OCT. And this is the image of a true papilledema, and that we cannot see the nerve, the borders of the nerve. We can see hyperemia, we can see vessel ingurgitating. And the OCT is the optical coherence tomography that can help us in these cases of pseudopapilledema, because it can study the retinal layer that will be thicker in these cases. So talking a little bit about the MRI findings. So the empty cella, we have this image here, so we cannot see the gland inside the cilia. Also, the distension of periodic arachnoid space, and we can see this tortuosity in the optic nerve and the flattening of the posterior part of the globe. But these in children may not be present because the optic nerve in children is more distensible than in adults. And in the angio MRI, we can notice the transverse venous sinus stenosis. So these are the findings that we are looking at. So this chart have a good review of this criteria. So the patient, if he has papilledema, we are going to look at all the other patterns to be sure that there is not a secondary cause for the papilledema. So normal brain parenchyma, normal venous imaging, normal CSF composition, and normal neurological examination. If it has higher opening pressure, so this is a definite IIH. But when the patient don't present papilledema, we have to have an increased opening pressure. And if we have a 6th nerve palsy, this will be a definite IIH. But if we don't have a 6th nerve palsy, so we need to have 3 patterns of the 4 MRI changes to say there is a suggest IIH without papilledema. So as we saw, the diagnosis criteria is really hard. So it's a package deal that we have to look at. And in the same manner, the management is also challenging, especially for surgeons, because when we have a problem, a patient with headache, we want to treat fast to release the pain and to improve quality of life. But we have to keep in mind that the first line therapy are medications and lifestyle changes. So we have these 2 papers in the left side here that shows that when we have 6% of decrease of the body weight, we can improve papilledema and we can improve signs and symptoms, and this is achievable. 6% of the body weight is achievable to treat these patients. And there is randomized control trial going on that compare the bariatric surgery patients with the community weight loss patients with IIH to see if there is a relation between the degree of weight loss and the symptoms of IIH. This is really important, the headache management. So we know that 2/3 of the patients, even though they are treated and the papilledema is released and also depression is controlled, we know that 2/3 of the patients will stay with a headache. So headaches do not correlate with opening pressure, with degree of papilledema, and with visual field loss. So surgeons have to control themselves not to put a shunt in these patients only because of continual headache. Headache must be managed medically and not surgically, and because of that, it is important the follow-up with a neurologist that is specialized in headache. So medical treatment, we can use acetazolamide and topiramate. Acetazolamide is a carbonic anhydrase inhibitor, so it will act in the aquaporin channel 1, which perform production of CSF. So acetazolamide can reduce the CSF production. And in the IIH trial, we saw that acetazolamide can improve visual fields, CSF opening pressure, papilledema, and improve the quality of life of the patients, and the dose can go to up to 4 grams per day. And topiramate is also a carbonic anhydrase inhibitor, so will perform reduction of CSF production and is a good medication to treat migraine headaches, and also has a side effects of weight loss. So patients with IIH can benefit from that, and the dose is from 25 milligrams till 100 milligrams per day. Corticosteroids can be used in the fulminant IIH with vision loss, but not in the long term, because it can cause weight gain, it can cause hypertension, it can cause blood glucose intolerance, and we already know about immunosuppression related to that. So it's not a medication to be used in a long term. The lumbar puncture can be used to release symptoms, to measure the opening pressure, and to perform the analysis of the CSF sample. But the problem is that nowadays we know that when we perform lumbar puncture in 6 hours, the patient will have the same amount of CSF running. So nowadays, lumbar puncture is not used to treat. It can be used to release symptoms really fast, or for patients that are waiting for surgery. For example, in pregnant women, we can use the lumbar puncture, but it's not nowadays using as a treatment. And surgical treatment, we will decide for it when the conservative treatment is not enough to release the patients from papilledema. So we have 2 options, the lumboperitoneal shunt and the ventriculoperitoneal shunt. The problem of VP shunt is that the ventricles are small. So often we put the lumboperitoneal shunt. So this is the components of the shunt. We have a 2E needle to perform the lumbar puncture, a lumbar catheter. There is really soft, not to perform injury to the nerves that are inside the spinal canal, and the peritoneal catheter. And we can interpose a valve or not. So this is the technique. Is not a difficult technique. It's the same thing as a lumbar puncture, but we perform a small incision in the back to be able to perform tunnelization of the catheter. And after we perform the puncture, so the catheter is inserted here, and it's really easy to do. I think the big question for surgeons is when to put a valve, and when to only put a catheter on. And the Birmingham protocol, they use a valve which is external regulated valve, but we know that when we look at the literature, that there is a lot of paper saying that the revision rates are really high, and the explanation for that is that sometimes patients don't adapt to the use of a valve. So this is a case of mine that I treat. It's a young boy that arrived already with the diagnosis of IIH, and he had already a shunt, and he went to the ER because of headache and difficult blurry vision. And when we perform the CT scan, we can see here that the catheter is all inside the abdominal region, and it was only catheter without valve. So we always think that we can do better, right, for the patients. So we look at this and we say, well, maybe we are going to make a revision. So maybe we put a valve to control the drainage, for him to not have hyper drainage, over drainage. So we performed the surgery, and the catheter was well put inside the spinal canal. And even though we put the pressure really low, this patient didn't adapt to that, and he exposed this catheter days after, even though the catheter was fixed in the subcutaneous space. And at the end, we needed to review again and leave only the catheter without the valve. Another treatment is the optic nerve sheath fenestration, and this is reserved for the cases of fulminant IIH with visual loss and need to be done by the neuro-ophthalmologist. And this is a case of mine that we are investigating now. So we can see that the patient doesn't have a Chiari-1, it doesn't have hydrocephalus myelia. We can see here a tortuosity of the nerve, the optic nerve. He had a papilledema, and we can see that the ventricles are of normal size. And when we look at the angio MRI, we can notice that the transverse sinus and the sigmoid sinus in the left side are not fulfilled. So this patient is now going to arteriography to study the venous pressure, and this is based in this venous sinus stenosis theory. And this paper showed us that when we have a point of stenosis, we have to measure the venous pressure proximal and distal to the stenosis. And when the gradient is higher than 21 millimeters, this patient can benefit from stents. So higher gradient yields higher success rates. So now we have a lot of papers going out, being published, saying that patient can improve papilledema, can improve symptoms with this stent. So here we can see the point of stenosis, and after the venography showing the sinus, the point of stenosis fulfilled after putting the stents on. The problem is that some patients still have stenosis because of intracranial hypertension and not hydrocranial venous hypertension leading to intracranial hypertension. So we need to perform a long-term follow-up to be sure of what patients are going to perform this kind of procedure. And of course, we have to talk about emerging treatments. That's what gives us hope, is the knowledge of the science that can help us to treat these patients. So we know that GLP-1 receptor, GLP-1 is produced by enteroendocrinal cells that will activate by the vagal stimulus some points in the brain that control the satiety. So the satiety. So this GLP-1, when it's released, they say to the brain, okay, I don't have to eat anymore. And we know nowadays that GLP-1 is also present in choroid plexus. And when he's activated, he performs a decrease in the production of CSF. So now in 2023, we had this paper publishing showing that agonists of this receptor can perform weight loss and can perform decreases in CSF production. So we have to study more to be able to treat our patients, but we have hope for the future. So in conclusion, what I have to leave as a message is that making the correct diagnosis is really important because we have to treat well the patient, see if the secondary causes are present because the management is completely different, and also provide fast management to decrease complications as permanent visual loss. is really important to not worship the pressure because it fluctuates widely. So we have to treat the patient. And also, when we talk about headache, we cannot put a shunt only because of headache. We have to treat clinically this patient. So it's not what we can do to the patient, but what we can do for the patient. And of course, further research is important to study the pathophysiology mechanisms and to be able to discover more and more and to treat better our patients. Thank you.
Thank you, Dr. Porzenko. It was an excellent presentation. Does anyone have any questions? Any questions online? All right, perfect. So next we have a physician, he's an adult neurosurgeon. He's actually the chief of vascular neurosurgery at Georgia University Medical Center, the chief of the stroke program. And I'll tell you, you know, some of the work that he's done in the community has been transformative. He came down here at the beginning of his career and really has transformed the stroke program. And, you know, in pediatrics, you know, the things that we do, children are fairly healthy, generally speaking. So our numbers are really, really small. But when you talk about disease processes that significantly impact the community, and, you know, in this case, a state, an entire region of the state, the type of work that he's done in order to transform the way we take care of patients with stroke and the number of lives he saved is probably countless. So it's a pleasure for him to be here, Dr. Panakanjippa.
Nice. Thank you for that, Lawrence. That was probably a somewhat undeserved introduction, but I appreciate it nonetheless. Let's get myself set up here and then I'll start sharing my screen. I want to thank Lawrence and everyone who's been involved with putting this day together and inviting me to speak here today. It's a real honor to be able to talk about adult hydrocephalus. Let's see if we can. Are we able to see it?
Yep.
All right, awesome. I have a fair amount to go through here, so I'm going to go kind of quick. So apologize if you need to stop me at some point because I'm going a little too fast. Please feel free. But I want to try and make sure I get through everything here because I think some of the subjects are going to be kind of interesting. There will be some surgical videos in here, so if anybody's a little bit squeamish, I'll tell you when to close your eyes. Okay. So as a kind of brief overview of what we're going to be talking about here, just an introduction, clinical presentation of adult hydrocephalus, diagnostic workup, treatment, and then some illustrative clinical cases, which are usually the most important things, no disclosures. So unlike pediatric hydrocephalus, adult hydrocephalus is typically a secondary phenomenon. Pediatric hydrocephalus, like Dr. Daniel said very eloquently, much more eloquently than I ever would explain, it's usually a CSF pathway disorder in pediatric hydrocephalus. Whereas in adult hydrocephalus, it's usually a secondary to some of the things that we are seeing up here: intracerebral or subarachnoid hemorrhage, strokes in the brain tumors, meningitis or infection, head trauma, post-craniotomy. You just had a great lecture on pseudotumor cerebri, and you're going to have another one on hydrocephalus. So I'm not going to touch on those two. But again, these are typically something else happening in the brain that then leads to the hydrocephalus development. It's been an increase in incidence over the past few decades, almost double. And possibly that could be from an increase in radiographic studies, or just, we're treating more things in the brain, treating more brain tumors that we didn't used to treat before, treating more types of hemorrhages that, the populated patients would have, not be able to survive, that they're able to survive now. So we're going to be managing a lot more hydrocephalus in adults than we ever have before. But it's really important to understand the interaction between the underlying disease and how the hydrocephalus is associated with that. That really makes guiding the best treatment choices. Oftentimes the hydrocephalus is what presents, that's what brings the patient medical attention, not the underlying disease. And one of the first cases I'll show you is an example of that. But the symptoms that you had in adult hydrocephalus are a little bit different than kids. The cranial vault is fixed at that point because, all the sutures, that put the bones together are, they're not open like they are in pediatric patients. So a lot of times headache, nausea, vomiting, cranial nerve palsies. Dr. Daniels showed that sixth nerve palsy that we were talking about before. You can also get other ones. The sixth nerve palsy is one that you can get. Visual disturbances, like you just saw in the previous lecture, weakness, lethargy, gait disturbance, falls, and seizure. There is one term that's out in the literature, which is something called hydrocephalus ex vacuo. This really isn't hydrocephalus. So sometimes when you have, let's say, a brain tumor or a stroke or some other thing where you've had injury to the brain, head trauma, for example, you might get loss of that brain substance. And what ends up happening is that the brain fills that with cerebrospinal fluid. And so you can get a CT scan or an MRI, and it might look like, that the patient has very big ventricles, but you have to associate that with the clinical symptom, right? Just like the previous lecturer was saying, you have to, look at the patients and look at their clinical presentation, not just what the radiographs look like. I remember a patient who was in, when I was in residency, so he was a practicing psychiatrist, and had a fall, hit his head, and got a scan, and I swear to God, his entire head was CSF for the most part. It was just a little ribbon of brain around, but he had gone his entire life, and that's how he had developed. And we didn't do anything because he didn't need anything done. It was, the fall and the hitting the head was just incidental to what was going on. It was very interesting sometimes to see how much the brain can compensate for, these injuries that it has. But again, you might come across that term hydrocephalus ex vacuo. Basically just means that the ventricles are bigger, but it doesn't necessarily mean that there's a problem. So the first step usually involves a detailed neurological workup, a detailed history and neurological examination. Subsequent to that, we usually do imaging. Typically, it's CT scan is the first line, MRI would be the second line, and then sometimes if you really need to look at things, you can do these nuclear medicine studies where you can actually look at how CSF is flowing through the cisterns, the fluid spaces in the brain. Lumbar puncture and intracranial pressure monitoring are also ways that we can work things up. So when you look at sort of adult hydrocephalus, this one here is actually a patient with normal pressure hydrocephalus. Again, I'm not going to go too much into that, but you see that the fluid spaces are bigger, but the subarachnoid spaces are relatively small. Whereas over here, this is a patient with, you can see inside here, this is intraventricular hemorrhage. And what's happening, you see this white spot here, this is where there's cerebrospinal fluid going across the lining of the ventricle system into the substance of the brain. Makes a lot of pressure because this is being blocked, right? So the mainstay of treatment for hydrocephalus in adults is CSF diversion. And most of the time, because this is a secondary problem, you can put in a temporary external ventricular drain to divert that CSF temporarily, treat the underlying problem, and then the patient doesn't necessarily have long-term hydrocephalus. But there are a significant number of patients who will require long-term CSF diversion. And obviously the ventricular peritoneal shunt is the most common, but there is an alternative, as Dr. Daniels mentioned before, called the endoscopic third ventriculostomy, which I'll show you an example of later. And so, I probably don't have to, spend too much time on this slide, because I'm pretty sure much everybody in this room is familiar with this, but, ventricular peritoneal shunt has three components to it. It has a ventricular catheter, which goes from the skull into the ventricle, the valve, which regulates the pressure, and then the distal catheter, which goes into the terminus via peritoneum, or the pleural space, or the atrium. And then an endoscopic third ventriculostomy, like Dr. Daniels was showing, and I'll show a video as well. If you're trying to poke a hole down here at the bottom of the third ventricle to communicate the ventricular system with the subarachnoid space. So really the main thing that you're gonna get out of this is seeing some of these cases. So I'm gonna spend some time on these. I have 3 cases to show. So case number 1, this is a 58-year-old female who presented to the emergency room with headache and altered mental status for several days. She had had multiple visits to the ER over the past 2 years for very similar episodes, and at some point she was kind of deemed to just be drug seeking. They would come in with bad headache, and they give her some medication, some like opioid medication, and she'd be discharged. Eventually she got to the point where she was an IV drug abuser because the ER stopped giving her those medications whenever she had these bad headaches. But this time, for whatever reason, they did a little bit more workup rather than just dismissing her. And she had a mild facial droop on the left side and decreased hearing in the left ear, but otherwise was neurologically intact. So they initially got a CT scan and they read hydrocephalus, that she had increased ventricular size, and subsequently got an MRI on her. And again, you see that the fluid spaces here are a lot bigger than they should be for a 58-year-old female. These should be sort of slit-like, almost not slit-like necessarily, but a lot smaller than they are. And sure enough, if you do a little more exploration, you see that you've got this very large tumor at the base of the skull on the left side, and this is around the area where the ear is. So that's the reason that she's having that decreasing in the hearing of the left ear, and also the facial nerve travels in that area. So she's got that drooping on the left side of the face. But really, what's very concerning about this is the compression of the brainstem over here, because if this continues to expand, she's going to have further problems because a lot of important structures and a lot of important nerves pass through here. This is actually probably one of the best examples I've ever seen of that, what we would call transependymal flow or transependymal resorption. But that's basically what's happening, is that there's so much pressure in the ventricular system that fluids can't stay inside the system. It's got to flow out into the substance of the brain itself. That's what causes the headaches, causes the mental status changes, things like that. I think when I first met her, she was like, almost to the point where she was like psychotic. She was, really, very difficult to, get her to participate with, the examination, and she was combative and stuff like that. And it's interesting to contrast that what happened after we treated her. She's like such a sweetheart now. So, like I said before, the MRI showed the hydrocephalus. It's caused by that large left-sided skull-based lesion. And so the initial plan was, let's treat the thing that's causing the problems, right? So we put it in a ventricular peritoneal shunt, and you can see the remarkable difference in the size of her ventricles. There's no pressure, none of that flow around the, none of that flow around the ventricular space. And, again, she almost immediately after this got better clinically. So we discharged her, let her recover a little bit, because that lesion that we were, at the base of the skull, that's kind of a complicated lesion. That's, kind of straddling a lot of really important structures over there. And it's gotten to the point, unfortunately, that it's so far along that curing that thing, meaning getting all of that tumor, is probably, unlikely. So we brought her back several weeks later for an operation to remove that tumor. And the goal was really, let's get the pressure off the brainstem and establish a diagnosis. It ends up being something called a schwannoma, which is a benign lesion, but it's causing problems because of where it's located and how much it's grown. So we do something called a retrosigmoid craniotomy. So it's in the back of the skull over here, like behind the ear. And we're sort of opening up this area because that's what's going to lead you to the area where the tumor is. So now you can see, that big tumor that was there, we basically poured all of it out. And then, afterward, you can, based on the pathology and things like that, you can radiate the residual that's there. But she still had that residual left-sided facial droop and hearing loss. Unfortunately, that, typically doesn't get better if it's a long-standing problem. But she's been able to return to a relatively normal life and is back to work at this point. So, again, manage that hydrocephalus, and then, figure out what's going on with that underlying problem. And that's, kind of the steps that you got to take, going through these. I'll show you a case where you got to do things in a little bit more real time here. In the second case, this is a 62-year-old female, so presented to the ER with after suffering a sudden severe headache and right-sided weakness followed by lethargy. If you're any of the neurosurgeons in the room, you probably know where I'm going with this based on my specialty. But she was intubated in the ER because she was getting so lethargic, she couldn't really protect her airway. We took her for a CT scan. So this is obviously a different looking CT scan than some of the stuff you've seen before. But all this white here, this is what's called subarachnoid. So remember that the subarachnoid space is where that CSF gets reabsorbed. So if you have blood sitting inside there, that's going to gum up the system, and the patient can get buildup of that spinal fluid here in the ventricular system. And that's like the secondary injury on top of the fact that what this patient had is a ruptured brain aneurysm. That subsequently led to this hydrocephalus, which adds insult to injury there. So again, patient found to have subarachnoid hemorrhage due to a ruptured aneurysm in what's called the left middle cerebral artery. It's kind of the artery that goes to the left side of the brain. And she also had associated hydrocephalus because of the blood clots in the CSF. So initially we placed an external ventricular drain, and thankfully the patient had improvement in her mental status. And then we took her for treatment of the aneurysm. So this is a 3D representation. Actually, you can see the ventricular catheter right here. And that's going to fluid basis in the brain. But this little bubble here, which is probably about 5 millimeters or so in diameter, maybe a little bit less. This is the culprit here. This is where the bleeding, the source of bleeding was that caused the all these things that happen. So we did subsequently an angiogram, which kind of looks at this thing here. And so this is the aneurysm that that bled that we need to treat. And so in this situation, we were able to treat it with what are called coils. So we basically take a small catheter, all the way from either the femoral artery, or nowadays we go through the radial artery in the wrist, bring it all the way up into the artery in the brain, stick it into the aneurysm, and we can deploy these coils that block off the aneurysm on the inside. So after the operation, patient had any further, bleeding issues, and sort of slowly improved. These patients are in the hospital for several weeks, and be really, really sick. But eventually she was able to be, stabilized enough that she could go to rehab. And this is a very typical story sometimes, where it's patient will go to rehab, they'll be doing, a little bit better for, maybe the first couple of weeks, and they hit what, the rehab docs will call a plateau. Not getting any better, you're just kind of staying still, whereas you would anticipate to be getting a little bit better every few days, every 2 weeks or so. So the rehab physician ordered a CT scan, and now you're seeing those fluid spaces in the brain that were, much smaller before, show these really, dilated ventricles. So this is what we call delayed hydrocephalus. And so that will lead to her worsening her clinical status. So we sent the patient back to the hospital to manage the hydrocephalus. And if you look back at this scan, you see that she's got really large ventricular spaces here, right? The spaces in the lateral ventricles are very big. But her subarachnoid spaces, these are actually normal size. So in this situation, instead of jumping to a deep jump, which I think most people do when you're dealing with adult hydrocephalus, we decided to perform an endoscopic third ventriculostomy. So hopefully this video works. This is one of our videos here. So I'm going to pause it for a second. So kind of like how Dr. Daniel showed you before, we went into the right lateral ventricle. And you want to see some, some important structures here. This is the choroid plexus. This produces that cerebral spinal fluid. And you see several veins here. I'm not going to name all of them, but they kind of give you, your anatomical landmarks to make sure you're in the right spot. And then you see this hole here. That's a fancy name called the foramen of Monroe. And basically this communicates those lateral ventricles with the third ventricle. So as we go a little bit deeper, we're going to go into that foramen. Here we go. So now we're going into that foramen. And just a second. So remember that translucent membrane that Dr. Nanos was talking about. That's where we're going to make a hole. These structures here are called the mammillary bodies. This is down here. It's called the cerebral aqueduct. So sometimes you'll get a patient has something called aqueductal stenosis. This area is narrowed down, and that could lead to some of these problems. But eventually, what we're going to do is we're going to get up to this area. We're going to make a hole in it. So, let's see. I'm a vascular guy, so I like scissors. Rather than cutting stuff, so. Put my scissors in there, and let's open up the spread. This is the ones that do it. There it is. Probably one more good measure.
Just really quickly, the way that we do these things, the techniques that vascular surgeons use, we're used to having to use sharp instruments to cut. Parts of the brain near these really important vessels, which you'll see in a second. And typically most other neurosurgeons we use less invasive techniques. So when we're in there and we're doing this stuff together, depending on who's holding the instrument at one time, we use this technique, I'll use my technique. And it's like seeing a married couple, argue about
Yeah,
who
it
gonna
is.
take the drive.
So, just gonna fast forward this a little bit, but you remember we talked about the balloon, and now you see that pulsation, see how it's going. Ba-boom, ba-boom, ba-boom. And, now we've got that communication between the ventricular system and the subarachnoid space. And this is that basilar artery. That's kind of like one of the most important arteries, and you want to make sure that, you study your preoperative MRIs and CT scans, because if, that thing's kind of high riding, that would be a serious problem if you end up damaging that vessel endoscopy. You don't really have a lot of places that, you don't have a lot of maneuverability to fix that. So we made that hole down here, communicated that CSF between the ventricular system and the subarachnoid space. This is just some additional on anatomy. This is the back part of what's called optic chiasm, where your two optic nerves come together. This red dot here is called the infundibular recess, which is what goes to your pituitary gland. This is actually basically the back part of the pituitary stalk. So that's the kind of master regulator of all your hormones in your body. So a lot of important stuff that you can get to, in this area. But to our last look, so here's a really good look at the aqueducts going down. Actually, see that hole down there that goes to the fourth ventricle. So, sometimes with these patients who have these really, large ventricular spaces, you can see some really awesome anatomy. And then patient really had an excellent recovery afterward. She was able to go back to rehab, and she didn't need permanent BP shunts. And this left her post-operative scan look like, so you remember how big those ventricles were, and now they were a lot smaller. There's a little dot of air in here, which is typical after you do these third ventriculostomies. But that was a really satisfying case, and doesn't always work out. Sometimes you try these and you end up needing to bail out and do a shunt afterward. But I think if you can avoid putting a BP shunt in the patient, I think it's always worthwhile giving him a shot. Now, like what Dr. Daniels was saying back when they first started doing these, trying to get everybody off of shunts, and unfortunately that's not where we are just yet. But there are some patients who will benefit from it. And so I'm going to go to the last case here, and this is it's probably the toughest operation of my career. So I'm happy to be able to share this one here with you. This is a 34-year-old female who was 28 weeks pregnant at the time she presented to the ER. And she had sudden onset severe headache, became progressively more lethargic. This was actually on New Year's Day, 2017. Yeah, it's not her. So, when I saw her initially, she was sleepy, but you could arouse her. She was moving all extremities. She didn't really have any what we call focal weakness. So we initially got CAT scan on her. And again, you start seeing this white stuff down in the base of the brain. And that's subarachnoid hemorrhage. If you look at the fluid spaces in her brain, again, a 34-year-old should have almost slit-like ventricles. These are much bigger than they should be. You see how like all of her sulci, the places where the fluid should be out on the outside of the brain, they're all compressed. And you see these things here, which are called the temporal horns of the lateral ventricle. These are all radiographic signs that somebody's having a hydrocephalus, and in this situation it's associated with this subarachnoid hemorrhage. So first thing you do is manage the hydrocephalus. That's actually, the headache is being caused by the presence of the blood in the brain and the aneurysm rupture, but the the lethargy that she's having is because of the hydrocephalus. So the first thing you do is put in a ventricular drain. This patient ended up having a very high opening pressure. But subsequently you got to treat the initial thing that's causing the problem, right? So we did an angiogram and showed that she had a right superior cerebellar artery aneurysm, not a very common location for aneurysm. It's really low down. And so unfortunately, this aneurysm wasn't amenable to treating with the coils like it was before. So we had to do an open operation. So this is the part where it gets, a little bit, you can see intraoperative videos here. But just pause it for a second. This is the aneurysm right here, this little thing. So this whole little thing right here, maybe 2 or 3 millimeters in size, it's causing all the problems. And this is kind of a 3D view of the same thing. So you see that there. This is kind of a working view of what it's going to look like in the operating room. So just to orient you a little bit, we've got a right-sided craniotomy underneath the temporal lobe, which would be kind of like right around here. And now these things are kind of a mess once they've bled. You see all this red around. It's not supposed to be. It should be like almost, crystal clear. But there's so much blood in the subarachnoid space. You see that's why she's developing that hydrocephalus. This white structure here is the third cranial nerve. You see some hemorrhage on it over here. And now we're starting to see some of the arteries. This actually is the posterior cerebral artery. We're going to trace that back to go down deeper and identify where the aneurysm is. So this is the superior cerebellar artery on the right side. We're going to follow this down. The aneurysm is going to be like down, way down deep. And now you're starting to see some of this, more fresh hemorrhage over here, this clot. That's where the aneurysm was. Skip ahead a little bit, just because this part's not super important. But now we're starting to see this is where the basilar artery split is, and the aneurysm is going to be like somewhere right around here. This is a pretty long reach. And again, this patient was 28 weeks pregnant at the time, so obviously there's a lot of there's high tension during this operation. You got 2 patients on the table right now. So we're just starting to see the aneurysm come into view. There it is right there. See that kind of cherry red spot over there, relatively small, but enough that we can get a little metal clip on it. Just clip. And we're going to use that to basically pinch off the aneurysm. And, for those of us in the audience who do these operations, is it's a long reach. So it's very far to get from here all the way down to the base of the brain. We do an intraoperative angiogram and it shows that the aneurysm's obliterated. So post-operatively, patient did really well. She had a transient third nerve palsy, but that resolved over the next 2 weeks. That's basically just from manipulating that third nerve while we were there. But we tried to wean that external ventricular drain, but unfortunately she was still dependent on diversion of the CSF. So what we ended up doing is putting in a ventricular pleural shunt. Again, remember she's 28 weeks pregnant, she's got a big belly here. You don't want to do anything, she may need a C-section or something like that. I think I did call it she needed a C-section. So you don't want to put a shunt catheter into someplace where something's going to be needing to do an operation soon. And also she's got gravid uterus and she's got it's just I'm not an obstetrician. I won't be going in there, so I decided to put it into the pleural cavity. So it just adds a little bit of complexity to an already complex situation. But she made an excellent recovery. Actually, she was discharged home after the operation, and since she's made a complete recovery and. This is what her post-op scan looks like. It's sort of 6-month angiogram where we don't see any return of the aneurysm, and this is the best part. 5 years later, that's that was I got to see her in the hospital right when she was born. I got to hold her, and that was just a really special case for me. And Glad that I was able to, sort of share that with you. That's all I got, guys. Any questions for me?
Thank you.
Dr. Deadpool, please, case one. How do you, in hindsight, when this is a patient who was kind of presenting to the ER and there were, I guess people kind of came to their own conclusions based on a myriad of factors, you kind of having to navigate the real issue. How do you then kind of establish, I guess, protocol, for lack of a better word, to keep that from advancing as far as it did?
Absolutely. So, one of the things you do is it's education, right? Just tell somebody about it, tell the people who are involved in that patient's care, because they'll remember that, so, I went and spoke to the ER doctor and said, listen, this patient actually has a real problem here. And we, I went back and looked at CT scans that were done 2 years ahead of time, and that tumor was there back then, and she didn't have the hydrocephalus then, right? So, that tumor could have been recognized 2 years ago. I went to the radiologist and told them, hey, take a look at this. You read this, this CAT scan 2 years ago. You notice anything? That one side, the skull looks completely normal, and one side the skull's not there. So, listen, we're all human, and I'm not blaming them for missing something that, in hindsight isn't so subtle of a finding, but you could have skipped over it. Clearly, multiple radiologists skipped over it over the course of 2 years. But again, it's about educating people and just letting them know, hey, this is what happened to this patient. Because the next time they'll say, you know what, it happened before, maybe I should just start over. And maybe just see if I can figure out exactly what's going on first. Because those types of things where you say patient, oh, they're drug seeking, or oh, they're coming in for, because they're malingering or whatever it is. That's after you've excluded everything else first, right? So I think we gotta check our biases at the door sometimes. Really just look at the person in front of you and say, hey, this is somebody who is coming for my help, and doing whatever you can. If at the end of it you find out, plenty of patients who are drug seeking and malingering sometimes. If you get to that and that's what you end up, diagnosing, or you don't find a diagnosis to explain the symptoms otherwise, then you can go to that. But you really gotta do a thorough job and say, hey, I did everything I possibly could to make sure that I ruled this out first, and then, that again, it's about just letting people know these types of things happen. It's not the first time this has happened, it's definitely not the last time it's gonna happen. But, we always try to get better by learning from our mistakes.
Thank you.
Yes, ma'am.
I really want to ask how gratifying it is to see the pulsation when you get the report. But the question I actually really have, I'm just.
The answer to that is very sad.
I look at it and I'm like, that's cool. I'm curious if you've started, when you're doing your surgery prep, if you've started using 3D imaging and VR, virtual reality, like VR, to kind of prepare for your surgeries at all, or if that's not really widely used yet.
So 3D imaging for sure. Those, matter of fact, on every shunt, for example, or any ETV, we're taking what's called a volumetric CT scan, basically a very thin slice CT scan, which can make a reconstruction of a patient's scalp and face, and basically it's like a GPS system. So that's the map, right? And what you do at that point is you're either, registering them to an optical system or to an electromagnetic system, which basically will tell you where you are at any given point during the operation. Because for tumor surgery, we do it for aneurysms, we do it for vascular malformations, and got to the point where every, ETV, we're using that. In terms of virtual reality, and actually, or I would probably just say augmented reality rather than virtual reality. There are some, AR tools that are out there where we can, kind of, you put the probe at the scalp, and you can, put it in a certain angle, and you can give a projection of where that thing's going to be if you advance it in that direction. We use that, during the operation, which I had I could probably show you a video, at some point. It's like playing a video game almost, because you're not even really looking at the patient at that point. Once you've done your, initial opening, and you put your devices, there, and you have your navigating system. You're basically looking at the screen and you're watching this and you're trying to like, make sure you go, follow that line and hit the target. It's like literally like you make it like a bullseye. It's like if you just get it right into the bullseye, you'll be good. So for both those third ventriculostomies and for the shunts, I rely heavily on 3D input and sort of augmented reality imaging. Once you in the third ventriculostomy, once you get inside the ventricle, then it's about understanding your neuroanatomy and making sure you're in the right spot. But
I guess you ever envision a day where you'll be with a patient and you'll both stick on a headset and you'll say, this is what we're gonna do during your surgery.
yeah, they have some systems like that that are out there where you can sort of plan your operation ahead of time and like I said, you can show the patient, hey, this is where they're this is what we're gonna do, this is the plan and stuff like that. They're kind of rudimentary right now, meaning they're not like as they're not ready for prime time for like a lay audience. They're like fun for surgeons to look at and stuff like that because you can slide in and out of different planes, we can change different modalities, you can merge an MRI and integrate them on top of the CT scan, and you can see how like, oh, I just want to see the blood vessels, or I just want to see these structures, I just want to see that. You kind of pick out each of these things. So it's fun for surgeons and doctors to do. I don't think that stuff is quite ready for the lay public, but I do see, envision a day where that will be the case. And I think that would actually be a lot of, it's probably not even that far away, it's probably maybe a couple of years away. And I think that would be a real benefit for patients.
I'm gonna make a comment. So, and there's a technology that we're aware of, it's a technology that's promoted to the public. Where neurosurgeons take imaging studies that are 3D imaging studies that developed from MRI or CT scan. They put on a virtual reality goggle and they kind of walk through the anatomy. I'm gonna be honest with you, because I have a tech company and we do things with augmented reality. It's really gimmicky, right? It's not a very useful tool to plan surgery because of the accuracy. But there's an organization in our area that's considered the #1 neurosurgery program in the country. And when they have their billboard advertising it, there's a bunch of doctors in the operating room dressed like they're ready for surgery, holding these non-sterile virtual reality instruments. That would never happen. So certain things about this technology, and I'm going to talk about this technology and its application, it's not practical and precise enough for the type of precision that we would require to do these type of things in spaces that are millimeters in size. But it's helpful to get a glimpse in what the future should look like. But he's really being polite and talking about how it might be a cool toy. It's not a useful instrument to plan some of the stuff we do. And another thing I want to say, he does use augmented reality when we're doing ICG under the scope. So sometimes for him to evaluate whether a blood vessel has been, a portion of the blood vessel that's at danger of rupturing and bleeding has been occluded. We do this under a microscope, and the microscope has the ability to change to a fluorescent lens. And we have the anesthesiologist inject a substance that flows through the blood vessel. So when we turn that lens on, we can see that substance flow. And the definition of augmented reality, which has been in existence since the 1970s, when airplane technicians were displaying instructions on data boards to kind of teach them how to augment the data boards. That's the pure definition of it. So you'll see an example of it here, but this is something we've been using in neurosurgery for decades.
Yeah, this is a case that Dr. Daniels and I did together. This is actually a really rare aneurysm. Matter of fact, it's actually in a similar location as the one I just showed. But this was, an aneurysm that we, clipped similar to like we did before. And so this is what Dr. Daniels was referring to, is that augmented reality where we're doing having the anesthesiologists inject that substance that then fluoresces under the microscope. And so it's lighting up with the blood vessels, but the aneurysm that was there before doesn't light up anymore. And this is what it looks like. So you see the blood vessel lighting up, the normal blood vessel, but you don't see any of the aneurysm lighting up, which tells you the aneurysm is occluded.
Right, and the pure definition of augmented reality is taking the real world and displaying either additional or supplementary information on the real world, right? To analyze or to instruct it.
I think that, technology is going to at some point, get better than us, right? Like our cars are gonna drive better than we do, and, even at some point, these third ventriculostomies. A neurosurgeon is gonna program a robot to just say, hey, you wanna go from here to here, and then maybe someday the robot will do it on its own. But just say, hey, make this hole like this, and that robot will go in, has no tremor at all, opens up the thing, almost bloodless, kind of procedure. That is probably decades, not, maybe centuries away, but like, the technology is continuously improving in that way. So it's someday that'll be, something that is commonplace right now. We're just kind of just getting started using these tools.
Can you click the Q&A? There's some questions for you.
Oh, sure. Right.
Just a quick question.
Go ahead, Sam.
I wanted to know in case 3, how big was her aneurysm?
It was tiny. It's like 2.5 to 3 millimeters. Yeah. So if you smaller than the diameter of this battery. Let's see. All right. So when you check
It's about
when you check our VP, all right, I'm gonna read this. When you check for shunt dependency, are VP shunt patients supposed to live with their shunt their entire lives? I would say an adult hydrocephalus, and actually probably, it's probably more so than in pediatric hydrocephalus. You could potentially outgrow your shunt or, get past the need for your shunt. Pediatric patients, Lawrence, correct me if I'm wrong here, typically they are dependent on their shunt pretty much their whole lives. But the vast majority even of adult patients who end up requiring VP shunt, have it for their whole lives. I would say you don't take it out unless there's a real compelling reason to do so. But every so often you'll take out a shunt, somebody won't be dependent on their shunt anymore. Let's see, can you talk about the meaning of the pressure numbers? That was a good, I probably should have done that during the talk. Most of the time, the pressure that you want inside the head should be about less than 20 millimeters of mercury. So anything greater than that is abnormal. Most people live with a pressure somewhere around 5 to 10. Maybe if you're, when we cough or we sneeze or something like that, it goes up transiently, but it comes back down to the normal number. But a patient who has an obstruction of their, fluid spaces in their brain because of a hemorrhage or a tumor or a head trauma or whatever it may be, could have pressures that are in the 30s, 40s, 50s, even higher. But if you let that continue for too long, eventually what happens is that parts of the brain will get adequate amount of blood flow that ends up leading to that area having a stroke, and then that can lead to subsequent problems and potentially fatal. Let's see, in the setting of non-compliant stiff ventricles on long-term shunted hydrocephalus, how do you impress upon the ER physicians to look beyond CT, MRI results? That's an excellent question. If I had a great answer to that, I would let you know, but I don't. I think I think it goes back to educating, right? There are times where, the ER will look at a read that a radiologist gives and says, oh, this is what the radiologist says, the ventricles are stable or whatever it is. And they don't even call you or they discharge the patient or something like that, and then they bounce back. But I think, you gotta go back and look at the patient moving in, listen to the patient. Dr. Daniel said it before. Most of the time, the expert on whether or not the shunt is failing is the patient and their family, right? They're going to tell you when that's failing, and you got to take it seriously because they know that patient, that shunt system better than anybody else does, because they're living the day to day. We're just, we're like, whatever. We made this discount tire. We're just, fixing the problem. You guys are driving the car every day, right? So it's, again, it's just educating people. I'm not doing it in a mean way, but just saying, hey, listen, that patient that you saw last week, I ended up taking some surgery because they actually had a blocked shunt, and it was, it's interesting because their ventricles didn't really change at all. And the next time they call you about it, and I think that's kind of the best way to do it. Just taking these case examples, taking these things that we learn, and then, educating the people who sit in the ER.
I have a question for you, from a patient's perspective. Because that was a really sophisticated question, and it could have been, the only type of doctor who would ask a question like that would be a neurosurgeon. But a patient, on the other hand, who finds themselves going to the ER time and time again and not being heard. What do you think an approach for a patient like that, who knows they're shunned and feels like the provider's not listening?
Yeah.
What do you think they should do?
I mean, unfortunately, that's, that's all too common. I think that, the only thing you really do is advocate for yourself and your family member, and just say, listen, I need to speak to the neurosurgeon on the call, because, I know something's wrong with my, daughter or son or my husband or wife or whoever it is, my family member or myself. If, I know something's wrong, please can you reach out to them, and it's important to have a rapport with a neurosurgeon that cares about hydrocephalus. Like, what's the number one thing adult neurosurgeons say about hydrocephalus? Like, I hate shunts, right? Even like, I talked about the pediatric neurosurgeon, and I said, what do you treat? I hate shunts, it's because it's like a complicated disease. There's like 9 billion different things that could cause it. Every patient's a little bit different, every system's a little bit different, so you get these very, very complicated things. We can't even figure out what happened because they've had 90 shunt operations in the past, and it's just a really, really difficult situation to get into and try and figure out, especially when sometimes these things are happening when a patient's coming in an extreme position. So, I don't envy, patients that have to, come to the hospital and come to the emergency room and have to navigate that situation. But yeah, I think at the end of the day, you gotta find, that person who's gonna listen to you and trust you and have that rapport with each other. That starts, well before you get to the starts in the office and
It's just a follow-up. So how often do you see your, particularly congenital hydrocephalus patients, how often do you see them routine care?
Typically it's like once a year, or if there's any, like once they've gotten past the first year, you're seeing them much more frequently, because again, you're typically, managing their underlying problem. Seeing one patients right here, and that's our order long class, that was actually awesome. What was I saying? So, yeah, I mean, sometimes you're managing that underlying problem that caused the hydrocephalus and then managing the shunt itself. I think if you get to the point where you're, every year everything's stable, you can probably stretch it out to a 2-year interval or even farther, or then, maybe you can at some point be like, hey, if you have an issue with it, let me know, but otherwise just go out and live your life. Sometimes, you get to that point, and that's, that's obviously like both satisfying, patient can fire me.
And that's real quickly, because you mentioned congenital hydrocephalus, which Dr. Jethro probably doesn't treat much, right? Because he's taking care of adult hydrocephalus, which is typically secondary to some other problem. But from a congenital hydrocephalus perspective and having a less likely probability that somebody would outgrow their system, I tend to see them once a year, irrespective of whether they're having symptoms or not, for the rest of my life.
Yeah. Got one more question over here. We talked about the shunt pressure and the numbers, right? And the numbers that describe it, but I guess it's the shunt pressure that I think that we talk about there on the valves, that actually depends on the type of valve. They all go in different, each sort of manufacturer has a different way of describing their pressure. Some of them go from like, 0 to 100 or 200. Some of them go from 0.5 to 2.5. Some of them go from 1 to 8 systems. Some of them go from 0 to 20. So there's a variety of different shunt systems out there. Unfortunately, you have to go to like the manufacturer's user manual or whatever to actually know what those numbers translate into actual pressures. But then that's something you should kind of explain to the patients and families once you put that type of valve in there. And then last question here is, when the shunt empties into the abdomen, can it cause digestive problems? Yes, it can. Typically not the fluid itself. Every so often, you'll get the shunt where it kind of coils around a loop of bowel. And I've actually seen that patients can get either digestive problems, sometimes they're gonna get bowel obstruction where they need to, actually have, a procedure done with, maybe go in. Either with a laparoscope or even an open abdominal operation to, move the catheter. That is extremely rare. One time. When I was in residency, actually not attending, I had a patient poop out their shunt. Which was wild, but I'm sure you've seen that too.
No.
How does that happen?
It eroded the bowel wall, and now it's in the bowel, and the bowel every, few seconds is, kind of pushing food along, and if the, catheter gets stuck on that, will.
Like it pulled it all the
It
way.
pulled it all the way out, yeah. Yes,
I'm sure there's a lot of variability, but is there an average length of time that an adult VP shunt lasts? And if it does need to be pulled, do you ever consider the ETV after?
so thankfully, most adult hydrocephalus isn't as dynamic as kids are because your skull's not growing anymore, your, CSF stasis and your CSF flow. Is kind of stabilized by the time you're an adult. So typically, I would say 90% of the time, once you put the shunt in, patients don't need to have, a revision done. Every so often, things will change, sometime maybe, and a lot of it depends on if they'll have a secondary injury from something else later on. Let's say they had a shunt, and had it for several years, then they have a stroke, or a head trauma, many years later, now they have another injury on top of it, now their shunt setting could change. Or they get an infection, or they get an obstruction. Again, most of the times if you place these things in the right spot and they, are functioning well, most of the times the adults don't need they don't need to touch it ever again. But if they do, that does present an opportunity at that point to see whether or not they need it anymore. So like, let's say, for example, somebody had a VP shunt in for, many years. They then, got a urinary tract infection, which then got into their bloodstream, which then infected the shunt. They needed to remove the shunts to, get rid of the infected source. You could sometimes at that point see whether or not the patient needs that shunt anymore. Maybe they, that primary problem that had been that they needed the shunt for in the first place has now been resolved for many years. Maybe they don't need it at that point. And then, at that point, you can consider maybe a therapeutic option might be a possibility. But they're again, thankfully, most of the time that's not what we're ended up having to do. Most of the time, it's that shunt's there for the rest of their lives, and it does its job. It doesn't need to be, your own brain is powering that thing, so it doesn't need a battery replacement or anything like that. And eventually that, they don't have to need anything further, but every so often, rare, but it happens. Really great question. Any other question? Everyone's ready for lunch, right?
Good job, yes. Right, so we take our lunch break. Now we'll take our lunch break and then we can try to get back in here. We're kind of went over a little bit, but I'm so thankful for all the presenters and you guys are asking outstanding questions. And so we ran over a little bit, but we wanted to get back in here by 12:30, but I don't want to rush you. But if you can eat, congregate and then get back here by 12:30, we'll get started with the second half. We're going to do one more presentation from an outstanding PF surgeon in London. And then after that, we're going to get to the I think my favorite part of the symposium, where we're really going to start sharing the perspective, the really human perspective of what it means to live a hydrocephalus, take care of patient hydrocephalus, and so forth. So enjoy your lunch, and I'll see you guys at 4:30.
And if I can encourage everybody to check out
Hi. Okay, let me just fix this quickly and then.
Welcome back, welcome back. So we're here for the second half of the annual Hydrocephalus Symposium. We're going to lead off with another lecture, a really close friend of mine and outstanding pediatric neurosurgeon, Dr. Karima Tazi. She's a pediatric neurosurgeon in London currently, but she's trained all over Europe, from Germany to the care hotspots in Paris, to London. I think she's a rising star in pediatric neurosurgery. She's a really close friend of mine, and I'm happy to have her. So, without further ado, we'll start with Dr. Karima Tazi, and her discussion will be about a phenomenon called normal pressure hydrocephalus.
I don't know if I should say good afternoon or good morning. Good afternoon, at least from London or Cambridge. I'm in London, but I work in Cambridge. My name is Karima Tazi. I'm very close friend of Lawrence's, and thank you so much for having me today to give a presentation about normal pressure hydrocephalus. And yes, I'll be talking about quickly give an introduction, diagnostics, clinical presentation, show some imaging, and then try to go into etiology and pathogenesis of NPH or INPH and the treatment. Normal pressure hydrocephalus is it's an old concept. It was introduced in 1965 by Hakim and Adams, and since then, actually never really understood, because we say normal pressure hydrocephalus, which is in itself a bit of a difficult assumption. But basically defined disease by two elementary ideas, by symptomatic ventriculomegaly and an accumulation of CSF with the normal range of the intracranial pressure, which is normally around 20 centimeters or less than 20 centimeters H2O. It's a specific form of communicating hydrocephalus, and there is a subdivision into idiopathic and secondary cases. I will try to focus on the idiopathic cases, which is more interesting because the secondary NPH is usually well known, and it's usually very, very common to the other forms of hydrocephalus, and is most of the time it's hemorrhagic or due to meningitis. As I said, normal pressure hydrocephalus, also known as idiopathic normal pressure hydrocephalus, it's not a rare clinical entity, and we think that the prevalence is greatly underestimated. The current data estimates 10 of 100% to 22 of 100% overall, and 1.3% in those aged 65, and 5.9 in those aged 80 years and older. And there is certain data that suggests that less than 20% of the people with that condition, with that disease, are not properly diagnosed. And as I said, one of the core features of INPH is that the cerebrospinal fluid, the CSF pressure, is within normal ranges. So how do we diagnose or should we approach someone we think they could have NPH or INPH, which is mostly it's clinical examination. A lot of the symptoms overlap with Parkinson's disease and Alzheimer's disease and other dementias. And once someone is suspected to have NPH, they should undergo a very thorough examination and assessment by a neurologist who is very familiar with these brain disorders or brain disorders in general that could affect movement, thinking skills, and physical functions. Brain imaging that we need is we can always do a CT scan. It's quick. It's almost it's quick and it's accessible for almost everyone. But we prefer doing MRIs because they can give us just more enough of an idea of underlying what's going on in the underlying tissue, and you can just make differential diagnosis so much easier. And there are other conditions that are that cause brain shrinkage, or that can also have larger ventricles, and sometimes it is just very difficult to differentiate between INPH and other degenerative conditions of the brain. And one of the very deciding tests we do is the CSF testing, which I will try to go into some explanations later. So measurements of CSF outflow resistance, intracranial pressure monitoring, and there is some people who do there's so many things, and one of the things is isotopic cysteinography. I don't think it's very popular these days, but it used to be very popular. So what are the symptoms of INPH? We call it this, so it's the so-called Hakim triad, however you want to pronounce it. And going back to it's the person who described it first. And the symptoms most of the time are levodopa unresponsive gait apraxia, which is one feature that distinguishes it from the Parkinson's disease. And it is difficulties in walking, and we always say we use a very, very nice description for it. It's like a person walking on a boat, and they're most of the time they're bent forward, their legs are held wide apart, and they're like glued to the deck. That is one of the most specific signs of gait apraxia in INPH. They can have mild dementia and cognitive decline, and in end stages they have urinary dysfunction and which is just loss of bladder control and incontinence. And these symptoms, as I said, it appears to be later than the first and the second one. And as I said, characteristics in the gait impairment, we do like certain tests. We test the patient and then see how long it takes them to do certain easy tests. We measure the step frequency, the number of steps, how long it takes them, and the ability to do a on-block 360 turn and how many steps it takes them. And these are very easy tests that everyone can do with a patient in his practice. These are some of the clinical features. As I said, yeah, I will go to detail with some of the other features. And some differential diagnosis. Most of the time, it's difficult to distinguish between Parkinson's disease because most patients develop the gait apraxia. This is the early sign of INPH, and a lot of times it's difficult to distinguish between Parkinson's disease and other forms of Parkinson's or vascular Parkinsonism. But we've always have to keep other dementia forms in mind, and Alzheimer's disease, frontotemporal dementia, and other causes of dementia or other causes for gait disturbances, gait dysfunction. Brain imaging, as I said, most of the time we do CT scans, and most patients get a CT scan first, and if there is some sort of sign of ventriculomegaly or just large ventricles, these patients should be further investigated, and then most of the time it is useful to have MRI imaging, and the MRI imaging shows very specific signs that we have to keep in mind when diagnosing these kind of conditions. As I said, ventriculomegaly is one of the most common, and then they can have periventricular hyperintensities, wide Sylvian fissure, as we can see in one of the trying to use my cursor. I don't know if you can see that, but wide Sylvian fissure and the narrowed subarachnoid space and cortical sulci, the high convexity. These are the radiological features very common in that condition. There are some changes in the MRI. Radiologists are very fond of doing these kind of things, and they help us because, as I said, INPH is a condition that is very difficult to diagnose, and sometimes it takes a very long time, and a lot of patients are not diagnosed, and it is very, very difficult. And despite the fact that it's been around for such a long time, there's a lot of things we don't know, and it is sometimes difficult to say whether a patient whether a patient should be admitted to a treatment or not. There are some very helpful measurements. The most of the time the radiologists gives us to decide whether this brain could be in a INPH or not. And these are certain indexes, angles, and then the so-called disproportional enlarged subarachnoid space hydrocephalus, the so-called DASH hydrocephalus. These are kind of things we do to see whether the patient should be admitted to further and we calculate the indexes and the angle, and then see whether there is a disproportionate enlarged subarachnoid space, and all these features can tell us whether this is INPH, and whether we should admit them for treatment, and whether there is a good prognosis for response. So as I said, Evans index, you can see the calculation. I'm not going to go into details, but basically the smaller the angle, they say the better, and then the better response to shunting, and and also if this is a common sign for patient, the DASH, that just determines whether a patient will respond good to any shunting treatment. Etiology of INPH. It's, as I said, very, very difficult to explain, and a lot of people we still don't really understand why it happens or why, and even if we do have some explanations for the pathogenesis of INPH, we still don't really understand it. And we think, and as I said, most of it just remains elusive, and we sometimes just do things to, well, we think it is the right thing. And we think that there is some kind of abnormal CSF dynamics, and the initial factor that contributes to the enlargement of the ventricles could be that there is just some abnormal flow or abnormal outflow, because it's not really clear whether it is the resorption, whether it is the production, because these are other types of hydrocephalus. So we think that there should be some kind of like disruption in the clear dynamics as we know them, as we can see. I mean, I just showed I'm sure you heard about it, but just a schematic explanation how basically there is some kind of production, and then there is the CSF flow, and then it's resorbed into these smaller structures, and it goes into the so-called sinuses, and it's drained away. And we think just because of age and of all changes in the vascular system, there could be some changes in these dynamics, and there could be something that could explain why actually that happens and why the pressure remains normal. Sorry, we go. So, and as I just explained, the resorption is normally a pressure gradient force, and it means that just that there is a certain production, certain circulation, and then outflow and resorption of the CSF, which is guaranteed from the sinuses, the structures that and the arachnoid granulations around the sinuses that guarantee the resorption. And some people think there could be some resorption that is done in the cervical lymphatic system, and that is also some research suggests that, which is a bit of a new assumption. And then there is some, as I said, some data that suggests that the CSF outflow is higher, that there is a certain higher resistance in the outflow, and that is basically what could explain the pathology, the mechanism of the development of INPH. And there is some research into this that has shown that patients who have INPH, and there's just certain infusion tests people do. I can show a little bit, there's data, I can show it a little bit later, where basically you do a lumbar puncture, certain lumbar puncture, and then connect a patient to an infusion system, and then you infuse a certain amount of saline or Hartmann's, and then measure the resistance, the outflow. And these patients who have INPH have showed to have a bit of a higher outflow resistance than healthy patients. So that's basically the what I just described. We measure a baseline, and then we measure after a certain infusion of fluid, of saline, And then we measure the resistance, and we can see that the resistance in these INPH patients is higher when you infuse. Basically, you infuse more volume, which would triggers the CSF dynamic resorption system, and then we can see that there is a certain increase in resistance just as a response to the CSF outflow or CSF production. That's a very useful study. We also use in not every hospital uses that, but when we're in Cambridge, we use this kind of study to diagnose or to help diagnose. I will show later the most common is the TAP testing. I will show this a little bit later. So then there's other research that suggests other potential mechanisms of ventricular enlargement, as I said, and there is some that we basically accepted that is a multifactorial condition, and it's very difficult to explain because we're dealing with elderly patients that most of the time come with a lot of other conditions, and which could be aging, sleep apnea, diabetes, hypertension. All these things change our brains. And then there is some research that says there is an impairment of the meningeal lymphatic system. There is some sort of CSF malabsorption, and then that causes dilation of the foramina, of the foramen majendi, and then there is an increased stroke volume in the aqueduct, and then some even say there is some kind of ciliary dysfunction in just the resorption, like the system that resorbs, and then also ependymal gliosis, which is all together with these factors of diabetes, alcohol, aging, and of course genetics, could explain why a patient after a certain amount of time or after they reach the age of 65 to 70 develop that condition. But as I said, this is hypothetical. We don't really know why INPH, and this is just a suggestion. I guess these are what the data we have suggests could be an explanation for the condition. Good. This is normally our treatment algorithm. Once we diagnose or we want to see if a patient could have INPH and could qualify to have some kind of surgical treatment, because at the end of the day, we are neurosurgeons and we offer surgical treatment. For INPH, there is actually no other treatment than surgery. There was, I think, some tests, and there was some assumption it could be treated with some kind of medications like acetaminophen and all these things, but they failed. So most of the common treatment for INPH is surgical. And once we've done the diagnostics and we have a patient that is 60 old, I would even say, because we used to say 70, and patients are getting younger and younger. So now the baseline is basically a cutoff is 60, 65, and they get the imaging. We calculate our indexes, and the events index is what the most common used, and then we look at the scans, and then of course we look at the clinical presentation, and if they present ataxia, then they could be TAP tested. It's basically just a lumbar puncture, and sometimes some departments do lumbar puncture, some departments do long-term over 3 days. A continuous CSF drainage, an external, which is a lumbar drain, because it's very easy to do it's a bedside test. Patients can stay in for a couple of days, and we just have a better idea whether they improve after we remove some CSF. And surprisingly, this is the most common, it's the most common testing for or the most reliable, because despite the fact that we say there is actually no overproduction, or the pressure is normal, they respond to a certain tapping or draining of CSF. So once we diagnosed a patient and they have a good response to CSF tapping, the most common, the fastest response is actually the gait improvement, which is most of the time one of the indicator we use to admit patients to surgical treatment. And once we decided, of course, and there's always patients, a certain amount of patients that have a very good response, and then there's patients who have who tend to have a response that is delayed, or let's just say that they respond well initially and then they don't really improve later. So there is a wide variability in the results, and I will try to show some results, but most of the time, unfortunately, it remains very inter-individual how long the response to a certain tapping will remain. So as I said, we do clinical we have clinical suspicion, at least two symptoms. Most of the time patients present in the early stages. As I said, it's the motricity, the gait disturbances, and the mental decline or cognitive decline, and then imaging, and then we either decide to observe or we do CSF testing, and then whether you have the possibility to do some CSF dynamics testing or just a lumbar drainage protocol is up to you. That is CSF. Not everyone has access to CSF dynamics because it just requires a brain physics department, and not everyone of your hospital has a brain physics department or a physicist who can give us, who actually, it's the brain physicist who evaluates and interprets the data, because you wouldn't expect us to do this. So it's easier to have someone who is familiar with these kind of physical changes of the brain to make it a reliable test. So we work together, but we have a separate department that takes care of these kind of tests. And then, as I said, lumbar puncture, at least 50 millimeters, the high volume puncture, as we say. And then you can also put a lumbar drain in. That's what we also do. We put in a lumbar drain over 72 hours and try to see whether they have an improvement. And the most visible, as I said, is the gait disturbances. The walking is much better after a certain amount of time, and that's when we decide to admit to shunting. If there's no response to the CSF protocol, to the CSF drainage, patients are not likely to respond, and the indication for surgery should be evaluated very, very carefully. Yeah, so surgical treatment, I'm not going to go into details because I think we've spoken, or I assume we've spoken a lot about ventricular or VP shunts, ventricular peritoneal shunts, or LP shunts, or different types of shunting. The most common we do nowadays is the ventricular peritoneal shunting, and this is the type of surgery that has just the most reliable results. And I've actually never seen anything else done, but there is literature that suggests some patients who have who had VA shunts, who had even ETVs, but they're not very successful in that kind of treatment. So the most reliable treatment is the VP shunting. And the difficult, as I said, the difficulty in INPH is the diagnosis, the initial diagnosis. And unfortunately, it takes some patients just because I think I assume general practitioners sometimes, or that they're not familiar with this kind of condition, or realize that this condition could be a possibility, or could explain the symptoms for a very long time. So most of the time there's a delay in the diagnosis and presentation, and unfortunately there is now I like the vocabulary. There is a difference between early shunting and delayed shunting, and patients who are admitted early to have diagnosed early and admitted early to have surgical treatment just have better outcomes, because most of the time, if patients the symptoms have been present for a very, very long time, or for many years, they're unlikely to be reversible with VP shunting. And as we can see that here, we just have in the patients who have been early diagnosed and early treated just have a better survival and long-term survival than these patients who are. It's just because, as I said, they have a better quality of life, and the symptoms are better reversible, and it just explains that their outcome will be better. But as I said, unfortunately, this is one of the most difficult things to have an eye on in the diagnosis, is the early diagnosis. And I guess as soon as we see a patient with suspected INPH, they should be admitted to a certain extensive diagnostic evaluation and assessment. And then some of the data that just presents the improvement of the mental state, and the improvement of the mental state before and after the VP shunting, and the response to the ventricular to the surgery. And so overall, once a patient is admitted to surgery and goes through surgery, the gait improvement, I mean, we have an overall improvement of all symptoms, and the outcomes are better the earlier the patient is admitted to the diagnostics and treatment. And gait showed the highest maintenance of baseline, and overall, if some of the studies follow up the patient over 7 years, and have seen that they can maintain their gait improvements up to 83% in 3 years, and 87% in 7 years. Cognition showed intermediary improvement, but still there was an improvement, and the urinary incontinence showed the least improvement, the least improvement, because as initially said, it is a symptom that comes in the late stadium of INPH, and it's probably because this is one of the latest symptoms. That means the patient just the symptoms have been around for a certain amount of time, and that's why that kind of symptom is not really well responding to, or at least responsive to the treatment. There is a certain amount of shunt complications, and can be up to 53%, but because just of these patient cohort, this patient cohort is elderly, is fragile, so there's still a very, very high complication rate, and some patients need a second surgery, a third surgery before they actually are happy with the treatment that was offered to them. And most of the time it's so I'm not going to explain all the possible shunt malfunctions and shunt, but they're like in every other patient that we operate on. So shunt malfunction, then the complications are just shunt malfunctions, infections, and changes of shunt configurations. We tend to have patients that need, nowadays most shunts we can change the or adjustable pressure settings. There used to be a time where people just have fixed pressure, and I think the complication rate was much better, much higher. We have better results now with better functioning shunts, and most of the patients sometimes have to come back because we just need to adjust the perfect shunt settings for these patients. And that means sometimes they have to come back to see the clinician or the surgeon for several amount of times until we actually find the perfect settings for that person. Yes, that's the end of my presentation, and happy to take questions.
Questions from the audience?
There's one question online. How common is NPH in adults under the age of 60?
If someone has the picture of NPH under 60, it's very unlikely to be INPH. They should be seen for hydrocephalus, but it is unlikely to be INPH.
Any more questions? Rima, thank you so much.
You're very welcome. Thanks for having me.
So next, what we are going to do is we are going to invite a patient up. We're going to invite a parent up, and then we're gonna all sit and talk about our experiences with hydrocephalus from our perspective, and then answer any questions that anyone might have about what it means to be a doctor taking care of patients with hydrocephalus, what it means to be a patient with hydrocephalus, and what it means to be a parent with a child with hydrocephalus. All right. Come on up. Right, so we'll start with introduction. So ladies first.
I'm Chloe, and I'm a patient that has hydrocephalus.
And then go ahead, Ken.
I spoke a little earlier, but my name is Dan Nima, and I am a parent of a hydrocephalus patient.
And my name's Dr. Lawrence Daniels, and I'm a pediatric neurosurgeon, and I take care of patients with hydrocephalus. Okay, so Carly, briefly, give everybody, I guess in your own words, an understanding of your relationship with hydrocephalus and how hydrocephalus affects you as a patient.
So growing up, I never let hydrocephalus affect me because I didn't have any issues growing up. But then later on, like once I got in high school, I started having some issues going on with more full vision that I'll talk about later. But because of that, it made me want to become more involved in the Hydrocephalus Association. And I'll talk later on like about starting a walk in the support group for New Jersey, because there was nothing in New Jersey at the time when I was going through it, and I had to go into Manhattan. And so I knew that there were more people like me that felt alone. And so I knew that New Jersey had to have something so people didn't have to go so far.
It's amazing. You mentioned something, that, I think, and I'll talk to you guys about my relationship with hydrocephalus. But I think from my perspective, it's kind of lost on us. You mentioned you felt alone. And describe it for me in what sense?
So at the time, I didn't know anyone else that had it, and I didn't realize that there's so many others out there that do have hydrocephalus. And so I thought I was the only one, and then later on, I found out that multiple people have it.
Yeah, a lot of people have it. The way that I describe it to a lot of people is I say, listen, any given year walking around the grocery store, to work, to school, you are going to run across somebody with hydrocephalus. You're going to run across someone with a VP shunt, and you may not notice it, you may not see it. You can't tell that Carly has hydrocephalus, you can't see her shunt. But there are enough of us in our population, there are enough of us in the United States that you're going to encounter someone with hydrocephalus and has a VP shunt out in the community. All right, Dan. Tell us your relationship with hydrocephalus. You told us, you've given us a lot of background. But remember, this is the second half of the symposium. There's probably a lot of new people here. But you've given us a lot of your background. And in one sense, we can glean from that background your relationship. But what I would like is personally, right? Your encounters with hydrocephalus, what hydrocephalus means to you in your life, and what is your disease with hydrocephalus? I mean, your relationship with hydrocephalus that you've been through.
Well, like I said earlier, I had no idea at all about hydrocephalus, what it was, anybody who had it, the numbers, some of the statistics concerning hydrocephalus. Dr. Google was not the best friend after my daughter's diagnosis, so we started Googling everything. You get those crazy images like you talked about before, and then you don't really know where you're going. You don't really know what to expect. You learn more as, you meet more people. Like I met you, I met Harley, I got to meet more people involved with AJ. You learn their stories, and I guess, it makes you feel better. Like you said, you felt alone. I didn't feel that at all because I got to meet you, one of my first events doing anything involving hydrocephalus was one of our walks. And you get there's 18 teams, everybody's in a good mood, and everybody's there together. You know what you're talking about. You know that there's other people that are going through what you're going through. So for me, it was kind of the opposite of what you said. It was the diagnosis and your immediate surgery is very scary. But as my daughter progressed and we got more involved, it was nice to know that there are other people that are going through what we are, and then there's such an immense, vast network of neurosurgeons and hospitals and researchers, and this is something I think is on the up and up. Even some of the companies here today, with some of the technology that they're coming up with, is just incredible, and it's gives me a lot of hope. Yeah.
I think about your story, and then I also think about Carly's story, and I think about myself, and I'll describe to everyone my experience and perspective in terms of my relationship with hydrocephalus. But when Carly first came to the Jersey Shore, I had recently got privileges at the hospital. I was giving presentations on a technique, an approach to a rare entity called cranial cerebral disproportion. And I developed a surgery to treat it and a technique to treat it. And I presented this work all over the world. Then I presented it down at the Jersey Shore, and all of a sudden people start getting a hold of me to doing more and more here, that I was eventually invited to get privileges down at the hospital. And so not really understanding the community and walking through the hallways, already had treated only one patient with hydrocephalus at the time. I was consulted to take care of Carly, which she was struggling, but she had mentioned that, through her childhood, it wasn't really an issue. And like a lot of people, when you make that transition, and when your body makes that transition between being a child and being an adult, your requirements from a drainage perspective change. And the shunt system that might have been working for you for your entire life, it's not working as well. And now you have to deal with that. And a part of that might be a series of studies and even a series of surgeries. In Carly's perspective, that can then put you in a completely different world. And Carly's respond to that, Carly and Carly's mom respond to that was, we didn't know that we could receive that care here. And we know that there's a lot of other people who don't know. And at that point, they're on a mission, right? When I think about hydrocephalus and how hydrocephalus has Carly's relationship with hydrocephalus, and this is what I want for all of my patients, is Carly's relationship is triumphant. Right? Hydrocephalus turned Carly into a advocate, into a pillar of the community, into someone who had recognized that there was a deficiency, right? And she wanted to fill that gap and that hole. And I tell you, it was all grassroots, and they did it by themselves. And now to hear your relationship with hydrocephalus is impacted by that decision that they made to bring in community around it where it didn't exist. And I think the walk that was last week, this hydrocephalus day, it's all a plant that was created from that seed, which was really just a patient saying, you know, there's more that can be done. This loneliness that she refers to is something that you don't refer to. The adjective that you use that makes me feel really, really good inside is that you were meeting with all these people who were having a good time, right? That's very different than Carly's perspective of imagining having something done to you when you were a child, before you had memory, living your life, and then all of a sudden, as you're becoming a teenager, dealing with this thing that you never really have to deal with in that way. So I think that's beautiful. I just want to say that. So, from my perspective, and I think a lot of neurosurgeons would agree with this. I'm looking at Dr. Jiffer right now. He mentioned something. I love Panakian because he's going to tell you how it is, right? He's between and he said something that a lot of neurosurgeons feel, and it's that there's a lot of trepidation associated with taking care of patients with shunts. Because you can read the textbook all you want, and you could follow the guidelines. I think Karima's discussion was really, really important because she talks about what we don't know so much. And we've talked about entities that we don't have a direct answer for, and we're still learning and trying to figure out. But we as neurosurgeons, we still have to treat you. And Panakin referred to patients who might come into the hospital under duress, right? Who already have their own history and relationship with their shunts. And now you just meeting this person is called to do something really, really heroic. But on the opposite side of that, it's also something that's really, really dangerous, and it's something that's really, really risky. And there's a certain amount of humility. It's hard to humble neurosurgeons. That's my wife. But there's a certain amount of humility that comes with approaching those circumstances. And for me, my relationship with hydrocephalus is a very humbling relationship. I was just having a discussion with parents. And a patient of ours that we're going to meet, who I think is an exceptionally young man. I inherited him from one of my mentors. And most of the way that I approach neurosurgery and I approach shunts has been seasoned by their experience. Not just the technical aspects of what it means to take care of a patient, how to perform a surgery, how to do a surgery quick enough to decrease the rate of infection associated with the patient, how to clean a patient, repair a patient, braid a patient's hair, to not cut their hair, but remove their hair so that they're not being looked at like an alien when they go out to the grocery store a couple of days. All these technical things that go into what it is we do and how it's passed down from one neurosurgeon to another. One of the most important things that are passed down is sensibility, right? A conservativeness about how we approach shunts. And you acquire over time this respect for patients with shunts. So much so that it might paralyze you in your ability to treat them immediately. But like Dr. Jetwa hinted towards, sometimes not being cerebral no pun intended, not thinking about very carefully what you're going to do with the patient shunt, and considering all the complexities associated with all the unknowns and the individualism associated with one's own relationship with their shunt, right? Carly and I, we've had to do things where we take the time to extract personalized data from her. And these things we've had to done on multiple occasions as she's grown into a woman with hydrocephalus, from a child with hydrocephalus. That level of consideration is paramount. Because we've all been in situations where we've thought we've had the answers for a patient with a shunt, and we found ourselves in a conundrum, not even knowing whether we'll be able to get out of it or not. So as much as we save lives with some of the things we do, I love the fact that Dr. Jeff came and presented some awesome surgeries. And I had all my fellows kind of like, I was kind of a little jealous, aggregate around him a little bit, and he started showing them all these pictures of all these surgeries. We do those things and we don't bat an eye because we're trained to do them, and it's part of our role in society. But there is a healthy amount of respect and humility that comes with how we have to approach these things. And to me, you know, one of my hardest cases should have been one of the easiest things that we do in neurosurgery. One of the first things we learned to do, and we'll talk about this early when we talk about technologies. One of the first things that a neurosurgical resident learns to do is to place something called an external ventricular drain. And it's a bedside procedure that we do. And when you get good at it, you should be able to do it in 10 to 15 minutes max. Because oftentimes when you're called to do it because you're saving someone's life. Because they have hydrocephalus in a way where they're moments away from their lives being taken from them. Their brain is exhibiting dysfunction in front of them. If you don't intervene in a matter of minutes, they may not live. So it's one of the first things we learn as a neurosurgical residents. We're really, really good at it. We can do it in a storm, literally. Sometimes we're in the ER. We don't have time to get privacy. Whenever we do this thing, everyone's paying attention, everyone's looking, everything stops. And none of that stuff can bother us. We have to just get to doing what we need to do to relieve the pressure on that patient. Well, although it's one of the first things we learn, and most of us could literally do it with our eyes closed, I think that Dr. Jetwan and myself can feel a patient and do it without looking. My most difficult case was an EVD. That something that could usually take 15 minutes, and this was during residency, with some outstanding neurosurgeons, took us 4 hours to get right. So my relationship with hydrocephalus is that of great humility and respect. And it's also with that oftentimes we approach our patients with caution and with a considerable amount of due diligence. Are there any questions for us from the audience?
I'm gonna start those.
Question,
Okay.
you allow them to talk. So, hey Joe, you're online now, we can hear you.
Okay, great, thank you. I've been in attendance all day. This has been so great to take it all in. So I'm a patient with hydrocephalus. I've had it for I was diagnosed back in 1992, and I got an ETV. Carly, your story is inspiring for me. It just brings up a lot of those old feelings. Like there was no community back then. There was no Google. There was no. I think of what my parents went through, just trying to find answers and really understand what hydrocephalus was. And growing up with it, I always felt like it was just this like cross I was carrying, and kind of tuned it out, you know, and it's like this trauma that I deal with. But I still have not really met anyone else in the real world with hydrocephalus. And my question to the group is just, you know, how can or what would you recommend to get more involved with the community? Because I'd love to help, you know, spread awareness for it and help other families. I've lived with this for over 30 years now, and I've made lived a pretty productive life with it. And I feel like I want to meet others that are going through it.
Yeah, that's powerful, man. Go ahead, I'll let you guys chime in, and then I'll have.
Where are you from?
So I grew up in northern New Jersey. We just moved to South Jersey a couple months ago, so I'm relatively close.
Great, well, we can get your contact information pretty easily through email or whatever, and
Yeah,
get a conversation going, jump off, and meet you, get to hang out, or virtual, in person, whatever you want to do. Get you involved and meet more people from our community in Jersey.
Right, and also too, at the end of my presentation, I'll have like my contact info at the end, and you can get it from there, you can send an email, or I think I have my phone number, and then you can send a text to me, and we can keep in touch.
awesome. That'd be great. I'd appreciate that.
The other resources like the Hydrocephalus Association, that, you know, a large part of what they do is develop a network and put patients and families and clinicians together to do this, right? This is the second time this has been done in the state of New Jersey. We want to do an annual thing. COVID kind of put the brakes on it. This is our first time doing it since COVID. But what I want to say to you, and I mean, I'm so glad you called. I'm so glad that they're getting spiffy with the technology and they
Yeah.
but that's what this symposium is for. It's for you. There's a, you know, all right, so when you do this at the hospital level and at the network level, there's always a conversation on return on investment, right? Like, well, if we do this, how many patients do we get? How many cases does this lead to? And that's how hospital systems have to run, right? Because they have to do things to bring in resources so they can open up other services. And for the life of me, it's been some work explaining to them that there's a phenomenon in our community, and I mentioned it before, and it is that it is important merely for us to create the awareness, because there are people with hydrocephalus, some people with shunts, and those shunts may not work forever. And those patients need to be made aware that there's a place where they can be taken care of, right?
Yeah.
And they should be also made aware that there may be symptoms that if they're experiencing, or their family members need to be made aware of symptoms that they're experiencing, that they can come and get someone to take care of them to make sure this is not going to lead into something that becomes dangerous to them. So making individuals like yourself aware is the name of the game, and each one teach one. You become aware, you become involved, you make someone else aware, and over time, hopefully what we do is we create the type of awareness where in our community, people know, you know, and become experts at their shunts and their hydrocephalus and how to utilize the resources surrounding them to take care of themselves. So I appreciate you having the courage to speak and share your story. And yeah, I can't wait to meet you. For sure.
Thank you all.
Thank you.
Any other questions?
Yeah, we have Kate next with a question. Kate, we can hear you.
Yes, I do. I was diagnosed first with NPH about 7 years ago, 2 years after that with stage 3 Parkinson's. I'm on Cinemet for the Parkinson's. I was shunted for the NPH, and things were going well, reasonably well until this past year or so, and I'm not responding to the Cinemet very well anymore. So my question is, how often you see cases with NPH and with hydrocephalus and Parkinson's, and what are the treatment options?
That's a really good question. So if there's anything you can take away from the NPH lecture, is one, that proper diagnosis of normal pressure hydrocephalus is a very challenging thing to do. So the neurosurgeon that gave us the presentation about normal pressure hydrocephalus was in the United Kingdom, right, where there's a public healthcare system. And as a result of that, they have resources that they assign and put together. Like she was talking about the physicists, right? And the department of physics. We have that in the United States, but we typically use it for stereotactic radio surgery. We don't typically use them for flow dynamics. And so the way that we make the diagnosis in the United States in most of our community hospitals and even some of our tertiary centers is far more crude. And as a result of that, They are patients that are misdiagnosed. One of the questions that I wanted to ask her, and I'm sure Panaka can relate to this, and this also goes with some of the hesitation to just jump to treat. And keep in mind, neurosurgeons get paid to do operations. So if you have a neurosurgeon that's hesitant to do so, that's a sign to you, right? They're looking out for you.
Right,
But
no, but in my case, this wasn't a misdiagnosis. Both diagnoses are correct.
I would be careful about that. And the reason why I would say that is it's really, the symptoms are so intertwined. Like, so one of the hallmarks of Parkinson's is the gait abnormality, right? And then possibly the memory or cognitive problems. And so oftentimes we'll have patients that come to us with those symptoms. And if you don't have a thorough and accurate workup, you might get diagnosed with NPH. The reason why that's an issue is because if you are being treated with Parkinson's, but you end up having a shunt, some of those symptoms that you experience that are progressive from Parkinson's, they're going to continue.
Right. But
Whereas
I don't think at the time that I was diagnosed with the NPH, I don't think I was symptomatic for Parkinson's.
what were your symptoms?
For NPH,
Yes.
it was gait. It was mostly gait disorder.
So that's
I was
that's
walking very slow. It could have been Parkinson's at that point. But
so that's one of the earliest, most recognizable symptoms of Parkinson's. Let me tell you why this is important though. There's a risk. We didn't discuss this, but there's a significant risk to putting in a shunt in an older patient with large ventricles in cortical atrophy that doesn't need a shunt, and there's a risk of something called over drainage. Now, over drainage in a younger patient can cause a headache. Over drainage in an older patient can cause something called a subdural hematoma, which is a bleed that occurs on the surface of the brain that then requires a surgery to treat.
right.
So, because of these two phenomena, one phenomenon of it being sometimes really, really difficult to diagnose normal pressure hydrocephalus, and the other phenomenon of treating someone with treating someone for normal pressure hydrocephalus when they don't actually have normal pressure hydrocephalus, leading to over drainage, it becomes a really careful balance that surgeons have to walk. The reason why I bring this up in your case, one, and I'm assuming you have a programmable shunt.
Yes.
So one of the things that can potentially be done if you have someone with normal pressure hydrocephalus that's no longer responding to their shunt is you can dial their shunt down and you can drain more fluid.
Right. No, we do occasional, right now we're doing occasional changes in the settings, but it's not helping.
So hear me out. So when you do that and you have a concomitant diagnosis of Parkinson's, you have an alternative explanation for your symptoms that looks really, really close to NPH. If you keep on dialing the shunt down, you might increase the risk of, this is really, really technical stuff, but
I don't know, I'm a pharmacology professor at a medical school.
yeah, I'm gonna try to speak to you separately about this.
Okay.
But you might find yourself, you're gonna find yourself increasing the risk of over drainage, and you might be chasing something that may not be.
Oh yeah, no, I understand that, and my ventricles are greatly expanded. They did not go down in size with shunting.
I'll also tell you, sometimes the ventricles don't.
Right, and so we don't, we use functionality as a readout, not appearance.
Yeah, so
so he's been very, very cautious with the shunt adjustments.
Yeah, I'm explaining to you the reason why.
Right.
But what we'll do offline is we'll really, because you understand all of this stuff, which is great. And we'll even go into some of the theories. Pressure hydrocephalus, ventricular compliance, things of that nature. Because from my perspective, it's this. We all work for you, right? But in order for this to work, you have to be informed. And sometimes I've had patients who come to me and I'm like, doctor, I've read everything, and I want to do this. And what I have to tell them is, you can read every textbook I've read several times over, But if you don't have the experience of taking care of patients,
Mm.
see how patients respond to therapy, what it means to treat somebody for NPH and then have to take their shunt out and take them to surgery to treat the over drainage. If you don't have a history of doing that, then there's something missing, right? But it's
Right.
still our responsibility to give you that information, right? And what I want to do is take an opportunity offline, really specifically talk about your situation and give you everything that I know so that you can arm yourself with that information and make some of the best decisions for yourself. But, and I know your surgeons consider these things, because it's just how we think about this stuff. And it's part of the reason why they're being so careful with dialing you down. But these are some of the complex considerations that go into treating patients, especially if you have a concomitant diagnosis of Parkinson's.
I just want to mention that, you have to take a team approach to taking care of, particularly in a situation like this where it's kind of complex, where you may have two diagnoses at the same time, or, the symptoms aren't responding anymore the way they used to. Having a movement disorder neurologist, somebody who really specializes in movement disorders, as part of the team, that's taking care of you for NPH is really important. And they're really, with their experience, they're able to tease out these little differences that tell you this is more like Parkinson's disease, this is more like, some other movement disorder, more like NPH, whatever it may be. And that'll help guide you to the correct treatment. Because likely if you had response to Cinemet at some point, with Parkinson's disease, you likely.
Right, well, my neurosurgeon recognized pretty early on after the shunt that there was something else going on, and he recommended that I find a specialist.
Yeah.
And I did, and he's the one that made the second diagnosis with the Parkinson's along with the NPH.
So that's the point. So now that, it sounds like the Cinemet isn't necessarily, I'm saying your particular case, but it kind of applies more broadly that if Cinemet's not working, the same way it used to in the past, then, most patients with Parkinson's progressive thing where you need to, have either higher doses or additional medications to manage the symptoms. And at some point it may end up getting to the point where,
Right. Well, right. We're kind of stuck right now between, well, is this a problem with progression of Parkinson's, or is it something going on with the NPH and the shunt? Is the shunt maybe not working anymore?
Yeah, that's a tough one. That's, that extent probably requires a longer, it's more specific conversation.
Yeah. I hope that was helpful.
But that's the hard part, is that there's a lot of patients with NPH in particular that could be explained with other diagnoses. And that's how you get humbled by, like Dr. Daniels was saying, that you think you got everything figured out, and it's supposed to be so straightforward. And, like it reads in the book, but patients don't behave like that. Everyone's got their own very unique stories, very unique circumstances.
Okay, so we have another, was that Kate?
Yes, it was.
Kate, thank you very much. Kate, if you want to.
Thank you.
Our doors are always open.
I appreciate it.
All right, so we have another question from an anonymous attendee. Question for the neurosurgeon: could choroid plexus cauterization help a shunted individual? That's a really, really good question. So along with doing ETV, sticking the endoscope in and looking through the microscope, if you notice in Dr. Jethwa's presentation, there was this little fuzzy yellow stuff on the floor right near those blood vessels. That's the choroid plexus. Those are the specialized capillaries that create CSF. And so there's a thought that if you coagulate the choroid plexus, it could also help to treat hydrocephalus. There is no one coagulating choroid plexus by itself. It's only done as a supplement to other things. The jury's not out on whether it's helpful. There is some additional risk associated with it. Some of those veins that you saw are actually fairly important veins, especially to the thalamus, and coagulating those veins can slightly increase the risk of having an hemorrhage or bleed, and that's an increased risk association with cauterizing the choroid plexus. So in itself, it's not, in itself has not shown to be helpful, but as a supplement to either putting in BP shots or as a supplement to ETBs, it might be something that's useful. And then last question, Thank you all for sharing the experience today. I have hydrocephalus. I have a hydrocephalus dog rescue, which wouldn't be possible without our human hydrocephalus relationships and research, connecting and advocating for all hydrocephalus warriors with an open mind, open heart, tremendously grateful. Oh, that was just a comment. Thank you, appreciate you. Yes, Debbie.
I was just gonna say something nice for one of our cutest patients around, LJ. We, one of our patients didn't make it today with his mom, and she said something really neat when we started talking about this, and she said, you know what, I need to brush up on my hydrocephalus information. I've actually forgotten. It's something they don't think about. And I was just gonna say, like, that's something, I know, I didn't know a lot about hydrocephalus because I'm not clinical, so I've learned a lot, and I've learned a lot from Carly, although obviously from Dr. Jethwa and obviously Dr. Daniels. But like, she went skydiving one day. And I was like, oh, I don't know what you can do and not do. And it appears, and you guys can tell us, and that's something to talk about. You can do anything, you know, and for a mom to forget that her son has it and doesn't even think about it, what a great place to be. And what great physicians and teamwork and everything. And I said, what a wonderful thing to say. And she stopped. And I said, what a neat comment. So, and with that, I think that's something for you guys to talk about. Like, I hope that's a day that it doesn't define you. You know, it's part of what you do and you do great things because of it, but that's one part of great other things that you do.
Come down here, Debbie. So this is my office manager, my secretary, she controls my schedule. And I just have to say, give her a thank you. Well, any of the speakers, wherever you are on planet Earth, right? The vendors, they've heard from Debbie on several occasions. She's probably more responsible than from anyone else for making this stuff happen and putting it together. This is your symposium as much as it is anyone else's, and I want to thank you for all the help that you've given us. Are there any other questions, or does anyone have anything else to say? If not, we're going to move on to our keynote speakers. No more questions? Okay, all right. So now, wait a minute, are we moving to the keynote speakers? No, it's not. I'm sorry, I have one more talk. All right, so then, thank you. And then one more talk. Keep it there. I'm actually going to invite down, I'm going to sit in the middle. I'm going to invite down two of my fellows. And what we're going to talk about is the future of hydrocephalus. Oh. So this presentation, from now on, is pretty laid back, and the symposium is more about, celebrating, everyone involved. And the next presentation that I want to give, you have to log back into Zoom. Hopefully this works.
You have the link still?
Yeah, I'm hoping I have the panelists when they go. Whatever's on my schedule, listen. Everybody now, just let your hair down. This is like. But so what we'll talk about is the future of hydrocephalus. And typically what I do is I talk about new technologies. I have to be honest. And my sister-in-law who attest to this. I literally was up at midnight doing this presentation.
Did you use ChatGPT?
No. I thought about it.
Maybe it's technology.
Just email it to you again.
Okay.
Okay.
Let me mute myself. And then I'm going to show the presentation. Now, the reason why I have my young guns up here is because we've actually, some of the things that I'm presenting were things that they brought up during our journal club. One of the things I'm presenting is augmented reality, with Harp up here. Introduce yourself.
Hi, I'm Herschel. I'm a second-year medical student at Hackensack Medical School, and I started working with Dr. Daniels maybe like junior year of college, so it's been a few years now.
So I'm John O'Hearn. I'm a graduate of Sequence Institute of Technology. I'm currently in the medical school application process. I've been working with Dr. Daniels since approximately last September.
Yeah. And then we have a couple other fellows up there as well. I'm very proud of. But so specifically, we start with, so we do journal clubs and then we work on projects. And I'm really keen into them, doing the type of nursery that I do. And I have a very unique and dynamic practice, we do independent research, a tech company, you know. We're working with other tech companies, anything that we can do to move the needle forward as it pertains to hydrocephalus and the care of hydrocephalus, we want to be involved in. And so we then get together and they are senior enough, they've had enough experience at this endeavor of mastering complex medical technology that they get to choose now what we talk about and what we guide. And so some of the stuff that I pulled up, which is I think is apropos considering, the younger people know the technology way better than us. And some of these things popped up. So because I did this thing last night, maybe 16 hours ago, this is like the latest and data stuff off the presses, right? And what's unique is a lot of the technologies that are now being implemented in treating hydrocephalus are the same technologies that we're using every day. I see people with their laptops, I see people with their Apple Watches. These same types of technologies, bioinformatics, machine learning, artificial intelligence, they're now being, used to treat hydrocephalus. So without further ado, let's get into it. So no disclosures, right? We're not talking about any of the companies I own or any of the devices I created. I have no financial relationship with any of the devices. We're going to go into training, right? How is technology implementing the future of training people who are going to treat people with hydrocephalus? We're going to go into the diagnosis. How is the technology influencing how we diagnose hydrocephalus, or in some cases, sentinel functions? And then we're also going to talk about treatments, right? How there are new and advanced technologies. I should probably even bring Dr. Panakian up there, because one of these technologies we'll be using to treat patients with hydrocephalus. And actually, he's the one who told me about the technology to treat patients with hydrocephalus. So, training. Okay, I'm gonna have Harsho go over the next slide. Listen, cut him some slack because he just learned about this a couple of hours ago. But he did bring to our journal club an article, right? About using augmented reality and mixed reality. So you have augmented reality, which is putting digital information on a real world environment. You have virtual reality, which is taking all of your visual senses and creating the context and background for that. And then mixed are other things that are kind of in between, but together we call mixed reality. So he's the one that brought it to our attention because it was something that he was interested in. Actually, Brian and I have a company where we use augmented reality to train. So we're working on that technology, and I told him I'll pull him into that if he's really, really interested in it. So we're going to let him present the next couple of slides.
So I know just as much about what's the next slides coming up as you guys do. So like Dr. Daniel said, like augmented reality is essentially like you're superimposing like a virtual image that like a technology is created for you onto a real life, like either image or like a live like video. And essentially it's trying to just like add like some extra layer of detail or simulation to what you're looking at live time in some way to help you out. And there's a lot of like different ways that it's used. And like Dr. Jetwell like talked about how like they have one where like it was like lighting up like the arteries to check if like the blood flow was like getting to the aneurysm or not. And there's like other applications as well. And a lot of these are like very early stages. So clinically they're not like as useful yet, but it's more just like developing them to get them to the point where they could be useful, not just in surgery, but like for patient education too. And maybe even in terms of like patient education, it might be something earlier on, because for that, it's more of like just a general understanding for the patient, not as much like specific details for the surgeon.
In this picture here that's up on the presentation, so you see someone holding an iPad, right? And then just beyond that iPad to the left, you have a screen and there's a digital image printed, right? That digital image allows the iPad and the program in the iPad to recognize that pattern and then load data. And that data is then presented at a proximity with coordinates direct towards the image, right? So this is kind of like augmented reality 1.0. We're transitioning a little bit beyond that, especially with some of these headsets that are more powerful and have computing capacity inside of them. It's part of the reason why when we talked about using augmented reality in the operating room, the reality of it is you don't have graphic cards that are fast enough. You don't have computing systems that are strong enough for someone to do this on a headset. It's just not accurate enough to use as a surgeon. We're approaching that technology. We're approaching the ability to do that. It's physically impossible. So when you see the picture of these doctors on the billboard, which is noisy so much, you can imagine, and they're in the operating room with these non-sterile devices with their scrubs on. You know, it's not serious, but it's designed to present what the future would look like, but I also think it's misleading because they're not doing that, right? The technology is not there yet. And I know it's some developing technology. With that being said, that's what you see in this picture. So when you look at the iPad, it's actually the camera showing the same view, but that spray painter is being presented digitally by the program. And that's really in essence what augmented reality is. This is going to be fun, the next slide, because he has no clue what he's about to do, but I'm going to explain what he's playing to you.
So this looks like it's scanned, so the headset he is on is scanning the QR code, which I guess is it's linked to that skull, which has a certain like fixed anatomy to it. And so they're using that QR code and the headset are communicating with each other. And then he's trying to insert the probe and kind of what Dr. Jethwa said earlier, determining what like the right angle and right approach would be for it.
Yeah, Jethwa, what is he doing?
Listen, an external ventricular drain.
Exactly, right? So remember what I told you, one of the first things that residents learn how to do. And the reason why we learn how to do it, correct me if I'm wrong, but the reason why we learn how to do it is because our senior residents don't want us waking them up at night and having to drive into the hospital to do this procedure, which absolutely has to be done at that moment.
I don't even know that stuff.
So, okay, I told you to do it with his eyes closed, right? So one of the first things we have to learn how to do is this. Now imagine though, right? That you have a computer system that can simulate that anatomy, right? That can allow you to know what Coker's point is, meaning what part of the body do you place that hole in, and that hole is not placed randomly. It's a very, very precise location. And once you place that hole in a very, very precise location, there are other landmarks we can use and there are other angles. You know, I kind of close my eyes when I think about it, because when you're learning how to do it, that's kind of how you do it. You're imagining these vectors coming off of different parts of the body that then will allow you to guide and place the shunt. And if you pay careful attention to the size of the ventricles in some of these patients, we've been looking at large ventricles, but you have a lot of patients whose ventricles are literally a millimeter in diameter, 2 millimeters in diameter. And you're trying to then, through someone's skull, looking at someone's CT scan, and then on someone's head with their hair, with a gown, with people in the ER staring at you, and when things moving, sometimes the patient's not even completely asleep, to be honest with you, and they're moving. You're trying to do all of this simultaneously while placing it. Now, it would be nice for us to be able to try this stuff on a mannequin, right, before we have to try it on human beings. And so that's where the technology. So go to the next slide.
It's the same thing as just showing, I guess it's showing like what exactly.
Subtle difference.
Yeah.
You see, if you look at the top left corner, you'll see a silhouette of the ventricles, right? And that silhouette of the ventricles is a digital interpretation of what that patient's head is. Now, one of the first things that we'll probably end up being able to do with augmented reality, once the computing power is accurate enough to keep the image still. If anyone does VR gaming, like Xbox has a new, or PlayStation 5 has a new VR gaming headset, and so you can play these games with it. If you ever play the games though, they're cool, but you don't want your surgeon using that type of technology. And that's the best technology we have up to date in terms of using that computing power, right? So, but what you can do, eventually what you'll be able to do is put someone's information from their MRI and CT scan, display it on a screen, and then use it in a similar way that we use the neuronavigation that Dr. Panakin was discussing to guide what you do. And Dr. Panakin right now, and a lot of us use a system like this to put in shunts, but it's not displayed on the patient through a goggle, because those things are not accurate enough. There's a computer system that's accurate to the millimeter. Like literally, like we don't use it if it's not within 2 millimeters of accuracy. And that's the type of accuracy you need to be useful for a surgeon, right? And then we use that stuff to navigate, right?
But
Yeah.
I mean, it looks like it's showing a two-dimensional image. Is there a way to, I mean, I'm sure at some point in the future, but how much more difficult is it? How much more computing power do you need to make it to get depth to that as well?
That's a good question. So think about what it means to display a 3D image there, right? Like say, for instance, in order for us to get accurate 3D information with the neuronavigation we use, we have to use landmarks, we have to use electromagnetic fields, or we have to use the lights where they have the points that are fixed to the patient in space and time. There's so much, and think about how heavy the computer is that we have to wheel into the operating room. And that computer only does one thing. That computer is optimized to really do one thing. It's an operating system on it, and there's one program on it. And you can hear the computer running while you're running it. Imagine how much computing power that is. In these devices, Panakin, what is one navigation system sell for? A modern navigation system. How much do we pay for it in the hospital?
I mean, it comes usually as an add-on with something else, but if it were standalone, I think it's like $200,000 or $300,000.
Yeah, it's about $250,000, right? For that computing system. So no, we don't have the ability to take that computing power and translate that into a set that you can wear on your head. The closest thing we've gotten to it is to be able to take that set and plug it into a computer, but still that processing computer power and the technology is not there enough to make it that accurate, but we're getting there. We're probably going to get there with spine surgery before we do with cranial surgery, right? With robotics. Any other question? All right, now, diagnosis. I'm going to take it over here. So this is a study that was published in October of last year. And it's a study that measures the volume of the CSF spaces, the ventricular spaces, and the subarachnoid spaces in a patient. And what they did to test the validity of this study is they measured this with different patients with different ages, and then they correlated to changes of those spaces with ages. Now, the technology that's used is a technology that's been developed by Fiji Films. It's called RELI. And it's a technology where you take, so Fiji Films, for us older people, they used to, make the stuff that we put in cameras to take pictures, right? We don't really do that anymore unless we want to be cool, right? We were at Brian's wedding and he had a photographer that actually took actual film. Is going to get actual film developed, but they're trying to be cool and they want a certain grain and stuff. But most of us, we take the picture on some form of digital camera. So Fiji Film has turned into a digital company, and they have machinery now that specializes in digital imagery, high-end MRIs, CT scans, you name it. So one of the CT scans you might use might be a Fiji machine. One of the MRIs you might use might be a Fiji machine. So now they're taking that data and they've developed a learning algorithm, which is essentially AI, artificial intelligence, that can now extrapolate more information than that data than most radiologists can glean from looking at a picture. And so the next slide, or you can imagine that this patient's MRI is being painted by a computer. Now, there are times when neurosurgeons, especially if we do something called stereotactic radiosurgery, where we have to identify an area where a tumor is located, and then we have to identify an area of the brain that's sensitive to radiation, maybe like the optic chiasm. And we have to give this information to a computer and to physicists. And the physicists then calculate, and then what happens is the machine takes beams of radiation from multiple different areas and focuses them on one area. So that one different part of the brain that you don't want to injure is not getting too much radiation, but they focus and concentrate in one area. When I was a resident, we'd have to, our attendings would make us sit in an office and just paint anatomy on the brain. The difference between that and what this program is doing is the program is doing it without a human being. And then it's just identifying those areas of the brain where the CSF is located, and then it's measuring the value. The next slide shows on the y-axis, the manual, meaning the human being painting the ventricles in each of the different slides, versus artificial intelligence painting the ventricles. And you see there's almost a direct correlation. Same thing with the subarachnoid spaces. So then it's taking these spaces and it's calculating it, and it's doing it based upon age. And it's showing something that we all know, that the older we get, the more our brains shrink. Your skull stays approximately the same size. So your skull doesn't want your brain wiggling around in the skull because it can cause issues, cause subdural hematomas, all these other different things. So what does it do? It replaces it with hydrocephalus. It's a similar phenomenon to what Dr. Jethwa talked about when he talked about hydrocephalus ex vaccio, where if you have a part of the brain that's injured and it begins to waste away because it's injured, the ventricles get larger to compensate for that loss of value so that the brain stays snug in the skull. So we know that there's a phenomenon where as we get older, we get more CSF. Now, are we dealing with somebody who has so much more CSF that maybe it's pathological? Right? Maybe it's normal pressure hydrocephalus, which sometimes is really difficult to diagnose, right? Well, we're getting to a point where a computer can measure, right, quantifiably the amount of CSF that one patient has in one imaging study at one time versus another. And that might be able to give us information that we've never been able to glean before as readily. And that might be information that we can take in our armament and maybe stratify some of those patients who are normal pressure hydrocephalus versus some of those patients who just have atrophy, normal atrophy that occurs with aging. And don't feel bad, our older patients, everyone's brains start to shrink after puberty. So now, wearables. So again, this is kind of, I love it. This is like a game show.
Wait, what's the next slide?
Exactly. So in this slide, what you see are people that are wearing things and devices that we all wear. I gave a presentation at the National Institute of Health, the National Library, that was called, the National Health Library. And it was a fundraiser for an organization that I'm on the board of. And this was, I think it was in 2016, maybe 2017. And at the time, the director of the National Library gave a presentation, and her entire presentation was on bioinformatics. You know, how do librarians catalog data that we acquire from devices that we wear that tell us about our body, right? And so now, several years later, we have a watch that we can wear that can tell us whether you're having an arrhythmia or not, right? Whether you've collapsed, it can call 911 for you. The first versions of the Apple Watch didn't have that ability, right? And how did we get there? And it has everything to do with how we use wearables. So, good.
Next slide. All right, so Rios, who many of you may have seen outside, is working on development of a device that you can place on your skin over where your shunt is. And now, as you know, it measures the shunt through the thermal conduction. As the shunt's working normally, the cerebral spinal fluid is flowing through it. And because it's flowing, there's a thermal conduction through it, and the device measures the temperature difference as it flows through. If the device, as a result, it takes all the stages to the bioinformatics that Dr. Jones talked about, and they're currently working on gathering this information. With the eventual goal of getting to the point where we gather enough information where the device can then tell if the shunt is failed due to a lack of flow through it, which be indicated by the stop temperature difference caused by the conduction of the fluid through it.
And actually, the device that they have out there right now can do that, right? Essentially tell you whether a shunt's flowing or not flowing. And to get in a little bit more detail, imagine something that creates a small heat signal, right? Where the fluid goes into the shunt. And then it measures the change in temperature as the fluid then goes to the end of the device. And measuring that the characteristics of that temperature change can give you an indication of whether fluid's flowing or not. And that's where they are now. And all they're doing now is the testing to be able to make something like that available to all of us. And why is that important? You both worked on a project where we were kind of creating we were designing a study for them, studies that they've already done, but we were designing a study for them to try to sort out why would something like that be useful. And Harsha, what did we come up with? What were our main concerns why a device like this would be important?
So a lot of the patients are like young pediatric patients, and so anytime like there's suspected shunt failure you essentially have to get some kind of radiologic scan, and any kind of radiologic scan except for an MRI is going to have exposure to radiation. And if you count up the amount of CT scans and X-rays that all these patients with hydrocephalus have to go through over the years, and you kind of like try to calculate their increased cancer risk, it's kind of astounding at certain times, like how much a higher likelihood is of developing a malignancy or just any kind of issues related with like continuous radiation exposure throughout their lives. So that's definitely very important. And also a lot of institutions that don't have a lot of hydrocephalus patients also aren't like great with identifying shunt failure. And like we've talked about, even patients like coming to the ER, but not like, even though they might tell the doctor like, oh, I think I have a shunt failure, might not be recognized properly. So like a device like this kind of helps to like add an extra layer of evidence and like like statistics and information showing that, look, I have a shunt failure, like I have this device that's telling me I might be, like my symptoms could be correlated to a shunt failure. So just like a lot of like different ways to improve patient outcomes and decrease the amount of radiation exposure they have.
And John, so now that's already been developed. I'm not gonna speak so much about what they're developing. I don't know what I can and cannot discuss. But let's just talk theoretical at this point. So now you have someone that has a device that they can wear and it can measure flow right through a shunt. That's something that we've never been able to do before. And the analogy I'll use is someone's Apple Watch, right? I don't even know if I want to tell the story. I was working out, and I was doing a run, and you know, I don't do as much physical activity as I used to. So I was doing a run, and my watch starts alerting at the end of my run, and it says your V2O max is low. And then so I Google it, I kind of look up, and it's like, yeah, it's like you really need to do this more often. If you want to make sure you stay healthy for the rest of your life. You know, my Apple Watch didn't do that when I first got it, right? And something occurs when you can accumulate that much data and you can pair it with, you know, these learning algorithms and these deep neural networks to glean insight on that data in ways that it was just really, really difficult for us to do a long time ago. So give me an idea of what you think you might be able to do with this device, but just take it to the next level.
Well, since you can put it on just to measure the shunt device, it also means it could come to do more longitudinal studies based on the shunt failure. People might be able to take it home. And then you can gather more information from the device, but also means that someone could get a warning about shunt failure before they even start coming to the report, which allows you to emergency room and get it treated.
So imagine, and although he does it so easily, because he went to Stevens School of Technology. But now imagine what it means to be able to measure what someone's flow in their shunt is doing all the time. And then develop maybe a profile, right, on what this individual person's shunt or the flow in their shunt is doing. And then imagine one day you get a slight derangement from that before someone has a headache, before someone gets nauseous, before someone even knows. And it's conceivable with enough data that you might then develop a predictive model that might be able to alert you when someone finds themselves in a situation where they might eventually have a shunt in the future. That would be a game changer in so many different ways in terms of how we treat patients with shunts. And I've seen some of the parents nod their head, right, because they understand that. And that's where this technology is moving, right? And so I think that's great. I'm glad to actually have you here. So Chad, thank you guys for coming. All right. Oh, and then this is the device being worn in real time. Now treatment. All right, so I have to thank Panakin for this because he was, I think it was, I don't know how he got wind of this, but he just sent it to me. And he was really, to be honest with you, he was talking crap to me. Because he was like, look at how we're going to be treating hydrocephalus in the future. Well,
then I saw how they do it. It's frightening.
So he's an endovascular surgeon. And what that means is he takes devices, he puts them in our blood vessels, he sends them all the way up to the brain, and then he manipulates those blood vessels in order to treat patients. And so, yeah, I'm glad. I don't think neurosurgeons are rushing to get in the business of treating hydrocephalus. Hydrocephalus is challenging, right? That's for real neurosurgeons, pediatric neurosurgeons, vascular neurosurgeons. Stick to all those aneurysms and stuff. So, but this is a technology that's emerging. And they're currently going through their clinical trials, and they've treated, I think they've treated a couple of human patients actually recently. But what it involves is sticking a catheter in the venous system in the leg, and then allowing that catheter to travel up to the veins, the jugular veins that ultimately end up going into the brain. And then at those brains that go into the brain, in a specific part of the brain, adjacent to an area called the CP angle, the cerebropontine angle, where we know there's a lot of CSF there, it's a subarachnoid space. Employing a device that punctures a hole in the vein. This is what I should do. I was like, I don't know about this. Puncture a hole in the vein, and then because going back to this picture, a significant portion of CSF is absorbed in the subarachnoid space, which has a greater surface area than the ventricles in normal cases. If you can open up one of those veins to the subarachnoid space, then that CSF can flow into that vein, which is the natural pathway of CSF flowing. So in this picture at the top, we have these structures called arachnoid villi, which is these one-way valves that when the pressure increases to a certain level inside the brain, those trapdoors open and CSF escapes into the sinuses, one of which is the sagittal sinus. So this device allows us to create some of these channels or channels that allow CSF when the pressure builds up to flow into the venous system, which is theoretically supposed to be more physiological. Any questions? All right, thank you.
Great job,
Yeah.
guys.
I'm gonna let my young bulls answer these questions.
Two specifically, I think for Reyes, one, is there now, or is there expected to be a similar device to detect if ETV has closed?
So I was actually gonna ask Chad to come down and answer these questions, but so, well, no. We already have a way to know whether the ETV is closed or not. And we can get an MRI and, all the neurosurgeons alluded to a technology that allows you to analyze the flow of CSF in the body. One type of technology is performed with an MRI, it's called a CNA flow study. And oftentimes we use this to check the patency of an ETV before we commit somebody to it and remove their shunt system completely. And because the way the MRIs work is it sends a signal to cells or to atoms in cells, and then that signal send that energy, it activates the energy, and then it sends a signal back to the computer system. If cells are traveling while that's happening, you get something called a flow void. And so you can see that artifact in areas where CSF is flowing pretty rapidly. So then you can't really quantify it yet, maybe on a 7 Tesla magnet, which are really, really powerful MRIs, really powerful magnets. They're really only used for research right now. But currently right now, we could see if there's artifact in the region where the ETV is located, and it gives us an indication whether it's working or not. So we have the ability to test whether the ETV is working. And then will the body device link up to an app? So yeah, of course it will. So yeah, it has an app that it links up to. I mean, I can't really tell you much about the device, especially the one I think you guys are referring to, because this device is currently in development right now. I don't know how much I should share, but what I will tell you is all the attributes that you would find in most wearables and the ways in which you use most wearables, there's no doubt in my mind you'll be able to use this device the same way. And it'll probably be just as powerful, if not more. All right.
There's one more.
Okay.
We have Gail. Gail, we can hear you. Gail, you may just have to unmute.
Oh, she has her hand up.
Yep. Prompted her to unmute.
It's okay, Gail. Do you want to type it in?
I'll keep an eye out for a question if you wanna.
Okay. Perfect. And if anything, if she types it in, I need to answer it later. I can do it. That's fine. All right, thank you. Now. Oh, did someone just raise their hand? Okay. Now, with no further ado. I mean, no further ado, because we're in like 20 minutes late. I want our keynote speakers to come and speak. So I want Carly to come up and speak to us. So she's going to give us a presentation about her journey with hydrocephalus. And I want Jillian to come up and speak to us as well. And he's also gonna rock out with us as well. I'm excited about this. So, Carly, welcome. Talk to us.
Alright, so now I'm gonna share my story with you guys. So a little bit about me, I'm a twin. I'm going into my second, semester of nursing school. And I'm gonna talk more about what I do for the association and all that later. So what I aspire to be, like I said, I'm in nursing school, so I hope to be either a NICU or a pediatric nurse. So all of these photos are with all of the pediatric nurses that I've had throughout all my hospitalization. So I'm gonna tell you about my hydrocephalus story. So this picture here, real quick. So picture on the right side of the screen. That is me when I was a baby in the NICU with my primary nurse, Ruth. And I always would hear stories about how she took care of me, and and she was like the main reason why. Well, one of the main reasons why I wanted to become a nurse, because I would hear about all the care that she provided for me and all the other NICU babies, and it made me want to be able to help other people. And so I always wanted to be able to meet her. So I got in contact with the hospital that she worked for, and we were able to make it work. I think it was about 20 years later after the first picture that we finally got to meet in person, and that was an amazing feeling. So the type of treatment that I have is a BP shunt, and so now I have a programmable shunt that can be controlled by getting the setting changed if needed. So this is before and after I have my trunk plate. So the picture on the right is of me in the NICU. Want to say about a month or so before I had my trunk plate. And earlier, like Dr. Daniel and everyone else had mentioned, is that when you're a baby, your head isn't, your skull isn't fully formed yet. And so as you can see, my head expanded because of all the CSF buildup. And then when I was 4 months old, before I got to go home from the NICU, I was in the NICU all that time. I had my trunk plate, and I can see the trunk help dramatically. So going forward, I'm going to share with you the surgeries that I've had because of my hydrocephalus. Quite a few. So I've had a total of 14 trunk revisions. The first one I had was when I was 13 months old. And then the second one I had when I was 9 years old in 4th grade. And so now going forward, I'm going to talk about here, I'm going to share revisions 3 through 8. So my third revision happened in April of 2015, over spring break, unfortunately. And then a few months later, on June 1st, I was at school when all of a sudden I started feeling like this pressure in my head. And the teachers at my school knew that I had hydrocephalus. And I was on a school bus, and I was like, there's no way I can go back to my other school that I was going to on the bus. There was no way. I knew something was wrong. And so I told everyone at the school, I'm like, something's not right. I can't go home like this. And so because they all knew I had hydrocephalus, they decided to call 911. And I was taken to the hospital, and I had a CAT scan done, and it showed that I was having a trunk malfunction. And so then I was then transported from that hospital to the hospital where my former neurosurgeon was at. And the following day, on June 2nd, I had my 4th revision. But then after that surgery, they did an MRI, I believe, and it showed that the shunt was not in the right place. So then the following day, I had to have my 5th revision, and then I was discharged, and a week later, I developed symptoms again of another trunk malfunction. And so then I had to went back into the hospital, and I was having another malfunction. And so I had to have my 6th revision, and then I was okay for a few months until October of 2015, where I had revision number 7. And then right after that, I was still in the hospital, but I had developed air bubbles in my head from the surgery, and so I had to stay in the hospital until they were dissipated. And so then, let's see, but then while I was still there, I went into a really bad malfunction again. And during the surgery, the neurosurgeon decided to disconnect the shunt that I had in the front of my head and reconnect it to a new shunt in the back of my head, but left the one in the front in that was supposedly not working. And so that was that. I was okay. But after having those 6 revisions in 6 months, I was like, that's not normal. Like, enough is enough. Like, I need to find someone else. And like I said earlier, at that time, after all those revisions, I felt alone. And so we were going into Manhattan for a support group meeting because, like I said, there was nothing in New Jersey at the time. And so we were doing that. And so then I ended up going to NYU a couple of times because I found a neurosurgeon there. And while I was there, there was a neurosurgeon, there was a doctor there that said, why don't you see someone locally? Why are you coming all the way here? So I ended up in the hospital again for an abdominal surgery. And like Dr. Daniel said earlier, that was when we met. And from the first moment I met him, I was like, that's it, this is where I'm staying, I'm not going anywhere else. And having Dr. Daniel as my neurosurgeon has been amazing. And I'm so glad we found him when we did. Because then, in about May of 2016, 2 weeks before my prom, the incision site from months prior, where the non-working shunt was, started leaking CSF out of my head. And so Dr. Daniel went in to remove it. And I was like, I told everyone, I came inside with from the moment I got to here, I'm like, my prom, and in 2 weeks, you gotta get me out. And so they did everything they could, and I made it to my prom, thankfully. But then I made it to graduation and all of that, and a few weeks after graduation, one of my abdominal incisions started leaking CSF again. And so I had an EVD done, and because there was a possibility that there was an infection. And so I had it externalized for 2 weeks, and then having it put back in, I consider that my 9th revision. And so I was okay for a good while until it was January of 2018. I was having headaches, and so Dr. Daniel did ICP monitoring, and then it showed that I was overdraining. And so at this time, Dr. Daniel decided to switch me from a fixed valve to the programmable one, so that way we would be able to change the settings that needed to be done. And so that was my 10th revision. And then, like I said, switched to programmable. And then later that year, in like June, I was having headaches, and so Dr. Daniel decided to add an anti-psyching device to my shunt, and that seemed to help for some time. And then Dr. Daniel had mentioned that there might be a possibility that I didn't need my shunt anymore at all. And so after having headaches and doing everything I possibly could with shunt adjustments and all of that, nothing was helping. So I said to Dr. Daniel, I'm like, okay, I'm willing to take the risk, and I'll see if I need my shunt anymore. So he took out my shunt, and we did a trial to see if I needed it. It turned out that I did, so I had to have another shunt put back in. It was my 4th revision, and that was January of 2019. And then 24 hours after I had that revision, I ended up having my first seizure. And it was a shock because I never had seizures before, and they said it most likely from like all the manipulation from all the surgery. But that was a scary time, but we gotta keep on. So again, I continued to, I mean, I was doing okay, but then I started to develop headaches again, and I said to Dr. Daniel that, because at the time, when you're overdraining, they say that Trendelenburg position works best. So like it's basically with your head down and your feet up, and that position should help with overdraining. So I was mimicking this position at home to test out if I was overdraining or not. And so I mentioned to Dr. Daniel that I really thought I was, and I would like him to do ICP monitoring. But then he, like he said earlier, he wanted to see if there was something else going on instead of jumping right to surgery. So he sent me to a headache center in Philly to see if I needed if I had headache syndrome. And even there at the hotel that we stayed at, I would put a garbage can underneath the mattress to create the position to be able to sleep. And so I mentioned that to them, and they agreed with me that I was most likely overdraining. So then when I got home, I contacted Dr. Daniel, then I went to the ER, and I had the ICP monitoring done. And like I had thought, I was overdraining again. And I had my 13th revision. And then I was okay, and then pandemic hit. And then back in the middle of the pandemic, in August of 2020, again, dealing with the headache, we decided to do ICP monitoring again because I thought I was overdraining. And I was. So I had my 14th revision, where we put a new programmable shunt in with an anti-siphon device. And this shunt has held up, so fingers crossed that it takes that way. So despite going through all of this, like I don't let it stop me from doing what I want. And obviously before I decided to go skydiving, I asked Dr. Daniel, and he was like, you don't have any limitations, go right ahead. I've been skydiving twice, and I got this tattoo as a reminder to myself that I am a warrior and I can get through anything. So like I said earlier, I had felt alone, and New Jersey didn't have a support group or a walk or anything. And so I reached out to the Hydrocephalus Association, and we made it a thing. And so now I'm in charge of the community network and the walk as well. So this is two separate families that we're with that were all patients of Dr. Daniel, Israel, LJ. And this is at one of our meetings that we had, like one of our first meetings we had at a restaurant, and Dr. Daniel came to talk to everyone who came to participate, and it was a great time. And now with COVID, we've been doing our meetings virtually, but it's been great. And so, so here's a little story real quick. So LJ was in a car accident, and he was in the hospital at the same time I was having to see if I needed my shunt anymore. And my family started talking to Olivia, LJ's mom, and just started sharing stories back and forth. And we decided to trade numbers just to keep in touch. At the time, LJ was there for the accident. He was going to be going to children's specialized. And then it's just crazy how it all works because we started to trade numbers. And about a couple weeks later, Olivia sent me a text saying, well, on the way back to the hospital, LJ had hydrocephalus. Meanwhile, if we hadn't met, they wouldn't have known anybody, and they would have been completely clueless. So we're great friends, and LJ's doing great today. So like I said earlier, we've been doing our hydrocephalus walk since 2017. Pretty much every single walk we've had, Dr. Daniels has been there. And this picture right here is from last year, when I met Dan for the first time, and Ollie, and it's been awesome. And so here it's a breakdown every year what our goal was at the walk and then what we have raised so far. Because our walk this year was just last Sunday, this is what the total was as of Tuesday. But I have a feeling that we're going to surpass our goal again. And I look forward to keep doing it and raising awareness and meeting new people. So thank you.
Carly's grown up so much. I remember the first time she was gonna speak like this. I remember us going through her presentation and her sitting there to talk and so forth. And just to see, you know, the advocate and the strong young woman that she's grown to now, it just warms my heart. So it's my group. Thank you. There you go. So now we have another patient, speaker, and you're kind of, getting the theme, these young people are living their lives to the fullest and they're doing exceptional things. And I think the most important thing we could do, with Hydrocephalus Day is to celebrate those people with hydrocephalus. And so the people who are the most important to me are the patients. And so I'm glad to have our patients speak to you and share their journey. So. Oh, we're gonna start off with the jam, right?
Well, we're gonna set up first.
Okay, all right.
And then we'll see.
So we can do two things. You can either play and speak, or you can speak and then you kind of lead us on the jam. I'll let you go, man. Do your thing. Bear with us, everybody. Oh.
You want me to make my thoughts?
Yeah.
Then you can jam us out? Sure. I'll go quick. I was just gonna thank everyone.
You can be their backup dancer.
It is not that late. You know what we do it. So, Amanda,
I had one.
so Amanda is the CEO, COO of the Hydrocephalus Association, which, is an organization that I was not aware of until Carly introduced me. But then when I looked into them, I saw so many of the most prominent, some of which are the neurosurgeons that mentored me, individuals who participated in the program and had brought symposiums to their state. And I think it's such an honor that they've given us so much assistance and given us so much support and being able to do something like this here in the state of New Jersey. So I'm so glad that she's here, and her team is here, and that they're able to assist us in putting the word out. So thank you so much.
And be bringing the day home, so I really was just going to reflect on everything that we've learned and say thank you to the incredible industry partners and Dr. Daniels for providing this day. So just a quick reflection. I think, Debbie, you brought up such a beautiful point. I have a 23-year-old daughter with hydrocephalus. She's had 17 brain surgeries, and I often forget too, right? I live and breathe this every single day at the Hydrocephalus Association, but it is really wonderful and humbling to be able to go back and listen from the beginning to the Hydrocephalus 101 talks and be reminded of all the different aspects of living with hydrocephalus and the medical complexities of it. And it is a complex condition. It's an invisible condition. And I think one of the things that Dan and Carly, and I'm sure we're about to hear, but from Julian, that living with an invisible condition can also be challenging in its own right, from an emotional standpoint, from just dealing with the chronic pain that might come up with hydrocephalus, but keeping a smile on our face to muscle through the days. And so it's complex in that way as well. And I think Carly and Julian, I don't know what you're gonna say yet, but I'm gonna thank you right now for it. And Dan, thank you for also reminding us about that and for all of the residents that are on this, on our Zoom, letting them get a little peek into that aspect of what it's like to raise a child with hydrocephalus and to live with the condition itself. I think that this hospital and these patients are really blessed to have somebody like Dr. Daniels, who is providing such incredible care to them. Because it's not just medical care that he's providing, he is a compassionate caretaker. And he truly cares for the entire patient and the entire family. And I think we also saw that in Dr. Jeffwa. And I don't know the two women medical providers who spoke earlier, but I would bet if they're friends with Dr. Daniels that they are exactly the same way. And so I just want to thank Dr. Daniels for putting this incredible day on for all of our patients. So I actually just wanted to
Oh. Wow. You did it without the slide.
That's good. So I just want to remind everyone, especially those of you that are watching and residents coming up through the system, know that we're here for your patients. The Hydrocephalus Association did start as a patient support and education group, but we do fund research now, and we are also very active on Capitol Hill. But we do provide one-on-one support, and that incredible woman right there, I'm going to point around, you have me on the far right now. I call her Sunshine because of her smile. Answers to the phone and provide and trains all of our volunteers around the country who are leading support groups like Carly and Dan, as well as peer support volunteers who are trained to be there for you on your journey. So if you need another mom to talk to, if you are a patient in your 30s and you need another woman to talk to, if you're a spouse and you need another spouse to talk to, we can connect you with those individuals. So we have support groups that are happening all over the country online that meet regularly, once a month, once a week, some of them, as well as in person. Carly showed a picture of hers. We also, I mentioned our Hydrocephalus Connect program where you can be connected with somebody on your journey. We hold educational events in partnership with incredible institutions like we're doing here today. We also have a physician's directory. So if you're traveling to California and you want to find somebody to know you're safe when you're out at Disneyland, you can look at our physician's directory and find doctors out in California who can provide care when you're out there. We have 25 of the leading neurosurgeons, neurologists, neuropsychologists, and nurse practitioners on our medical advisory board who read every single thing we publish about the condition. We are not allowed to publish anything about hydrocephalus without having them sign off on it. So you know that all of our online and print publications are trusted sources of information. And we have an incredible video library on YouTube if you want to watch Ask the Expert series with different doctors, other videos from our conferences. So really great place to go. We also hold webinars, so sign up to stay in touch with us and you can get emails about the different webinars that we host throughout the year. But I really want to point out that on November 4th, we will have a virtual conference. It'll be a five or 6 hour conference on Zoom. So I really encourage you to take a peek, hydrocephalusconference.org, and join us on November 4th. We do a scholarship program for people who are looking to continue their education. That can be college, that can be post-college. You know, Carly said she's in nursing school. You can use it for any type of advanced educational activities. And for our littlest patients, Lakeisha launched a pen pal program. So we have kids who are connecting with each other across the country and keeping and making new friendships, which is really wonderful. The other thing I just want to leave you with is we also have developed a free mobile app, and it allows you to track your entire treatment history. Living with hydrocephalus, you can also store images of your MRIs and CT scans. Our physician's directory is built right into it. It has a symptom diary, so you can track symptoms multiple times a day if you want, once a week, once a month. All of those reports can be exported. You can text them right to Dr. Daniels. So you're not feeling well, monitor your symptoms for a week or two, text him the report. He can see everything that's been happening to you. A lot of new changes are coming with the app right now. You can, we have a document library where you can store PDFs of radiology reports, for example. And we have a whole bunch of new features that are coming out, and we're kind of doing a big facelift to it. So in October-ish, it's going to be a whole new app, and we're really excited. So if you want to just take a quick second, you can use your phone and you can go download it for free. And I'm going to wait a second because I saw a couple phones come up. And if you're on Zoom, you can do it too. Got one? All right. And with that, this is my last slide. I just want everybody to know you're not alone. And I think that Dr. Daniels has really punctuated these points today. Connect with your medical team. You are your own best advocate, but you are also there. Your medical team is part of your journey. Your doctor is part of your journey, and they want to be a part of that. So connect with them. Connect with the different shunt companies and the different, like Rayos was here today as well. And so was Annuncia. So make sure that you're keeping abreast of all of the new technologies that are coming out to help treat you. Connect with them. I can guarantee you they want to talk to you. I'm right, right?
Absolutely right.
They want to talk to us and hear our perspective on the different types of devices that they're developing. Definitely connect with them. Connect with each other. There's nothing, you do not have to go through this journey alone. I have made some of my closest friends through this journey with hydrocephalus. So as much as I hate hydrocephalus, I don't know what I would do without these people in my life. So connect with each other, connect with Carly so she can connect you locally with people. And then connect with the Hydrocephalus Association. We are here for you. That is our mission every single day, to be here to support people across the country as we all journey together through this condition. So I really want to thank Rose and Annuncia and Aspulap and Integra for coming down today to support this event and to support the families. Again, can we give like a huge round of applause to Dr. Over because Julian's going to take us home, and I don't know, I might have to jump up here and dance. So thank you so much. And thank you for joining us online, and I'm turning it back.
Let's just give a little sound here. Check. Oh, you gotta bring that up. Check. 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 All right, yeah, that should be loud enough. Are we good, Julie? Yeah, that's good. All right. I'm gonna speak a little bit. Okay, here we go. All right. Hello, everybody. So, in all honesty, when I was asked to speak here, I didn't even know the term hydrocephalus. And you could say, well, you know, I've had this condition pretty much my whole life since I was 6 years old. Shouldn't I have known about what it was? And I guess you can say, yeah, that I should have, maybe be alarmed that I didn't, but in the same breath be proud of the fact that I didn't know really what I was dealing with until now. I lived my entire life pretty much unfettered by hydrocephalus until I was on a plane traveling back from a tour in Australia, and not long before we were shut down by COVID, and I was getting these really bad pressure headaches, and it was affecting my vision. And I chalked it up to maybe I was on a plane, my equilibrium was off, and I would stand up quickly, I would get lightheaded, and I would lose my vision for about 2 seconds, completely lose it. And at this time, you know, it was the first time I was experiencing something like this, and it should have been at that point where I thought about my shunt. I should have thought about hydrocephalus at this point, but I didn't know the term. Someone with a disorder of this nature, who has it their entire life, and didn't know the name of the condition, just goes to show you that we do need to bring awareness to hydrocephalus, even those of us who've had it a good portion of our lives. It wasn't until I really started to go blind and have hemorrhages in both my eyes that actually my mom, who's here today, brought it up that it might be something going on with my shunt. And first of all,
let me say that loved ones and people who love people with hydrocephalus, they're so important to have. And that support system, those people around you who can actually see you on a daily basis are really very, very important. And if it wasn't for my family, I probably wouldn't be alive today. When I was 5 or 6 years old, I was waking up in the middle of the night, not yet really conscious, but covered in my own vomit. And this would happen time and time again, night after night. And my parents took me to see some doctors. They didn't really know what was happening. They said maybe a stomach bug or a virus or salmonella or something. But it wasn't until my wonderful pediatrician, Dr. Anthony Lamantia, who is an attentive and caring doctor, who thought outside the box to recommend that we have a CT scan. It was a CT scan, I believe, then. And then we were recommended to a brilliant trailblazer in the field, the late Dr. Fred Epstein, who the doctors, I'm sure, here know of, who helped to pioneer technology, including lasers, ultrasound, and huge microscopes to remove mainly non-cancerous tumors that were once thought to be incurable because of their location. And as well as Dr. Epstein, a main person in my life was his esteemed colleague, Dr. Ira Abbott, who's a master neurosurgeon in his own right and the mentor to my doctor, Lawrence Daniels. It was then where we discovered a cyst in my brain. Dr. Abbott performed the surgery, and I went forward as a 6-year-old pretty much unfazed by the fact that I had now a shunt. The operation was so successful as a child, we really didn't know about it. I really didn't know about my condition or what I was dealing with. And I was able to live as a child. And I was quite the little monster. I had so much energy, I really didn't know how to channel it. And probably the best way I could was through music. And I was always a natural born drummer, and nothing was going to stop me from hitting things with sticks. My parents saw the interest. They started and got me some bongos, some stuff that was around the house. I got some practice pads, and eventually they bought me a drum set. I was uninhibited by hydrocephalus, and I didn't know about it. I was living my life until I picked up a guitar. Gentlemen, 1, 2, 3, 4. guitars, plays. I was in drum line, barely 5 feet tall with a big bass drum, then a snare drum. Then I drummed my way into a scholarship into Berklee College of Music.
Wow.
And it was the only place I wanted to go. And in 2013, I graduated with a degree in music business from the finest contemporary music institution in the world. The earth was my oyster. The planet, my playground. The sphere was my stage. The globe was my garden. And it was then when my professional music career began, and I was getting a lot of gigs actually as a guitar player. There was some opportunities, some auditions. I auditioned for this singer and producer Ryan Leslie, and I was the second call for him, super producer, Grammy-winning artist. And I didn't get that gig, but it certainly opened up a lot of doors. Then I was called by a bass player who was a friend of another musician friend of mine, who brought me into audition to get the gig playing gospel music in an amazing church. You know, a little Jewish white boy playing at a church that Whitney Houston and Dionne Warwick grew up singing in, New Hope Baptist Church in Newark, New Jersey, a historic musical site in our state. I even performed at the Prudential Center with Emily Sissy Houston, Whitney Houston's mom, an amazing singer who sang with Elvis Presley and has had an illustrious career in her own right. And if you squint and put it in slow motion, you can see a glimpse of me in the Dionne Warwick documentary on HBO, also in New Hope. And since then, I've been all over the country and actually all over the world playing music. And I've performed in most major cities in the US and been to Bermuda, Germany, England, Australia, performed privately for the Prince and Princess of Monaco with my friend Caroline Freeland, and all that just to play music, and I have a lot more places to go. I'm also an educator, and I've written curriculum and headed up a guitar program for the largest arts activities provider to public schools across all New York City boroughs called New York Edge, and I'm involved in local politics as well, and I'm a 3-time elected Democratic committeeman for Monmouth County. Also, I'm in a book club. And tomorrow, this band will be playing all original music at the See Here Now Festival in Asbury Park, which is happening right now. With the headliners, Weezer, Foo Fighters, Beach Boys are playing. With Sheryl Crow. And that's a major accomplishment for us and for myself personally. And so the question that I will pose is, do you think that I've been held back by hydrocephalus? Probably not. So in 2020, in the height of COVID, when I was experiencing severe cranial pressure and vision loss from a malfunctioning shunt, that I had, by the way, a whole 20 years without incident. Dr. Abbott, who couldn't do the surgery because he was too valuable to go into a COVID-ridden hospital to perform one. So my rock star, Dr. Lawrence Daniels, he did it. And I was admitted to the hospital, and that day, Dr. Daniels put together a team. That night, he did a surgery on my shunt revision, and the next day I was discharged from the hospital. And it might be a miracle, certainly is miraculous, but it actually was modern medicine, a few great doctors, and my loved ones who saved my life. So you could be that doctor or that person, that loved one who really makes a difference and helps somebody. So together we can bring awareness where awareness is truly needed. Celebrate what we can and will triumph over this condition, and we will rock on.
Once again, y'all give it up for Julie. Oh, this call is great. see somebody like him who went through something like that and see where they are right now, that's a blessing, that's a testimony, so.
Ladies and gentlemen, Alexander Simone. We're the Who Dat High crew. We got Mr. Kevin Stryker on bass. We got Andrew Davis on drums. Jamari here on keyboards. And Jules drummer. We're gonna play one for you.
My baby left me again. Now I don't know what to do. She says she always give up the side. That's not quite true. Now I'm stuck in
everybody. Thank you, Dr. Daniels.
All right, that's it.